Please put your hands together for a thunderous round of applause.
It's time to extend a grand welcome to our esteemed speakers and distinguished guests who has joined us for this prestigious international conference. Their presence truly elevates this occasion, and we are honored to have them with us today.
The exchange of ideas across the border is the foundation of progress. Together, we'll learn, grow, and build a healthy and better future. With this beautiful line, a very delightful and ebullient morning to all acclaimed speakers, esteemed guests, respected faculty members, and all the valuable participants.
I am your host, Khushi Bhausar.
And I am Sania Karma.
It's our great pleasure to extend a warm and beautiful welcome to each of you at today's highly anticipated conference on clinical trial, addressing practices, challenges, and global innovation.
This conference is hosted by our prestigious institute, GRY Institute of Pharmacy, which itself is paramount in shaping the future pharmacist.
GRY Institute of Pharmacy is a premier institute in Nimad region of Madhya Pradesh, established in year 2001 by founder chairman late Shri Subhash Yadav and run by Jawaharlal Nehru Charitable Education Trust.
The institute offers UG, PG and diploma courses in pharmacy approved by PCI New Delhi and affiliated to RGPV Bhopal. We take immense pride in being the first private pharmacy institute in Madhya Pradesh to be accredited by NAC. The institute follows outcome-based student-centric methods for teaching and learning and focused on student performances and learning outcomes.
This institute is spanning an area of 5 acres with the best infrastructure facility comprising modern audio-visual air-conditioned classroom, well-equipped laboratories, a technologically advanced computer lab, and a knowledge-rich library with 12,000 plus books and 30 plus national and international journals. The e-library has more than 2,000 books and 300 journals. This facility provides an ideal learning condition for the student having access to best resources for their academic and professional growth.
This conference is designed to bring the pharmacist, academic leaders, and students from different institutes to discuss the latest trends, challenges, and innovations in clinical trial.
Clinical trials serve as a backbone of medical advancement, ensuring safety and effectiveness of new treatment. These trials play a crucial role in evaluating innovative therapies, improving existing medical practices, and shaping the future of healthcare.
As we gathered here today, we aim to address and evolving the landscape of clinical research, exploring the best practices, overcome the challenges, and embracing the global innovations.
Clinical trials serve as a critical bridge between the laboratory discovery and the real-world treatment, ensuring that the new drug therapy and medical intervention are safe and effective.
Over the years, we have witnessed a groundbreaking advancement from the precision medicine to AI-driven trial designs. But alongside this development comes significant challenges, regulatory considerations, patient recruitments, hurdles, and needs for the global collaboration.
This conference is a platform where knowledge meets action. We are here not just to discuss but to innovate, to explore how we can make this trial more efficient with the experts around the world. To mentor all of us, we have two prominent experience holders of this field. As our speaker, Dr. Bethany Carpenter ma'am and Miss Alice ma'am.
Ladies and gentlemen, may I kindly request your attention? As we stand together in unity, It's time to pay homage to the spirit and pride of our nations through their national anthems. I humbly request everyone to please stand up on your place as we begin with the national anthem of United States of America.
Thank you. Please remain standing as we now honor the national anthem of Taiwan.
Let us stand in respect for the national anthem of India. Jai Hind.
Jai Hind. Thank you, everyone. Please be seated. To invoke the blessing of knowledge and wisdom, we shall now proceed with the ceremonial lighting of lamp. I invite our honorable chief guest, guest of honor, respected Arun sir, keynote speakers, and principal sir to kindly come forward for lamp lighting.
Thank you, everyone. May this flame be a beacon of learning and inspirations for all of us. Now, to give you all insights into our institution's general achievement, let's take a moment to watch a special video presentation on GRY Institute of Pharmacy. I hope you all enjoyed the glimpse of our institute's progress and contribution to field of pharma. We are honored to announce that this is the second international conference conducted by our institute. Before this, in year 2022, our institute successfully hosted its first international congress on global integration in healthcare management and drug development. Now, let's take a walk down memory lane as we showcase highlights from our last international conference.
Dance is a language of soul, communicating its passion without a word being spoken. So, to welcome you all and to mark the beginning of this conference, we are presenting before you a mesmerizing dance through the graceful art of Kathak. Kathak is one of the 8 classical dance forms of India, which is a perfect blend of rhythm, expression, and devotion.
So, for this, we would like to call Samriddhi and Rishika to present a welcome dance.
सुमुखश्चैकदन्तश्च कपिलो गजकर्णकः लम्बोदरश्च विकटो विघ्ननाशो विनायकः धूम्रकेतु गणाध्यक्षो भालचन्द्र गजाननः वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा ईश्वरनाट्या पूजितम् नमामि शङ्करपादवन्दितम् ಗೆಜ್ಜೆಗಳನಾದಾತೋಂತನಂ ಪಾದಗಳ ಕುಣಿತಾಧೀರ್ತನಂ ಸಂಗೀತ ಸಾಹಿತ್ಯ रघुकुल रीत सदा चली आई प्राण जाए पर वचन न जाए तदिया नदी दर तना देरे नो तदिया नदी
Wow, what a mesmerizing performance.
Now we request stage committee to arrange the stage.
Speakers, chief guests, guest of honor, chairman sir, to please take their seat on dais. We kindly request our principal sir to escort them to stage.
Atithi Devo Bhava. In Indian culture, welcoming guests is deeply rooted in traditions and hospitality. The concept of Atithi Devo Bhava, meaning the guest is a god, highlighting the significance of treating the guest with the utmost respect and warmth.
We feel privileged to extend a warm welcome to our prominent dignitaries. It's our honor to introduce our chief guest, Dr. Neeraj Upmanyu sir, Pro Vice Chancellor in Sage University, Bhopal, and a member of Central Council in PCI, New Delhi. Now, we warmly request Arun sir to please give a floral welcome to our respected chief guest. Sir.
It's our pleasure to introduce Professor Indrajit Singhvi sir as a guest of honor today. Sir is a provost of Pacific Medical University, Udaipur. Now we request Arun sir to welcome Indrajit sir with the bouquet. Thank you, sir.
We take immense pride in introducing our esteemed speaker, Dr. Bethany Carpenter, ma'am. Ma'am is a clinical pharmacy supervisor at Marine Health Medical Center in Green Bay, California, USA. We request Arun sir to please welcome ma'am with a bouquet. Thank you, sir.
We are delighted to have Ms. Alice as a prominent keynote speaker. Ma'am is a critical care pharmacist at Taipei Municipal Wangfeng Hospital, Taipei, Taiwan. Now we request Arun sir to welcome ma'am with the bouquet. Thank you, sir. A great leader is one who knows the way, goes the way, and shows the way. And behind every great institution stands a great leader.
Our respected chairman, Mr. Arun Yadav sir, is a beacon of wisdom, shaping the future with a vision that empowers the generation to excel.
To graciously welcome him, we respectfully request our principal, Dr. Sujit Pillai sir, to give a floral welcome to our respected chairman sir. Thank you, sir.
Education is the foundation of progress, and a great principal is the architect of that foundation.
Our dedicated principal, Professor Dr. Sujit Pillai sir, continues to inspire students and faculty alike with his wisdom and excellence.
Now, to officially commence today's proceedings, we invite our dignified principal sir for the welcome address.
Happy morning to everyone. Please accept my greetings for this second international conference, GRYPICON-2025. GRYPICON is GRY Institute International Conference. This year, we have planned for a seminar on clinical trials, addressing practices, challenges, and global innovations. So I heartily welcome all the dignitaries on the dais. It is very heartful to welcome our chief guest for today's conference, Professor Neeraj Upmanyu sir, Vice Chancellor, Sage University, and member PCI, Central Council member of Pharmacy Council of India. Sir has been very kind enough because he was traveling from last 4-5 days, continuous traveling. His health is also not good, but his love and affection has made us that today he is there with us to grace this occasion. And as I welcome you, sir, to our campus, and thank you for gracing the occasion. Now, as I start welcoming Indrajit Singhvi, sir, I started to get some goosebumps. He is my guide, my mentor, my teacher. Whenever I have some issues, he is the first person to whom which I look upon. I still remember the days of my PhD in 2003-04. Sir has said that you need to have 10 papers, then only I will ask you to submit your thesis. And sir, I am proud enough that I have completed 16 papers before submitting the thesis. And getting at that time seat in government university for PhD was very difficult, and I was kind enough to get sir's guideship for my PhD. Thank you, sir, for coming to our campus and gracing this occasion. I once again welcome you, sir. Words will be short if I don't mention Ms. Bethne and Ms. Alice for today's conference. I am continuously troubling from last 3-4 months. Day and night I am texting them, I am calling them, and they are very patient enough to answer my all queries. And I really appreciate the fact that you have taken long flight to travel. I think 26 hours flight was there from US, and taking all the pain just to make this conference in the shape which it is today. Thank you, Ms. Bethany, Ms. Alice, for coming to, and I'm sure that today's conference, you will be highly enlightened by the clinical trials, what it is abroad by today's conference. Thank you once again. This conference could have not been possible without the blessings of our chairman, sir. Thank you, Arun, sir, for guiding us for this. He says that you try to do your best and do your best possible way. That's why we have kept our college tagline as working towards being the best. And it is under his leadership and mentorship that we are very proud to announce that we are the first private pharmacy institute in the state of Madhya Pradesh to get the NAC accreditation. After us, many have been done, but we were the first. And also, we are the first institute in the state of Madhya Pradesh to get UGC autonomous status. Thank you, Arun sir, for guiding us and always motivating us to do our best. Thank you. Today, I warmly welcome today's session chair, Atul Shirketkar sir, Vice Principal, R.C. Patel Institute of Pharmacy. I thank you, sir. I know that today's examinations are there, and it was very busy for you to reach here, but yet you have made it here. Thank you, sir. A warm welcome to you. I also welcome my friend, Professor Nilesh Malviya, sir, who is also a session chair today. And let me congratulate you, sir. Today is your wedding anniversary. Let me congratulate you and Sapna, madam. Have a many more blessed years. Thank you, sir. And also, I welcome today's judges for poster competition. Sapna Malviya, ma'am, Principal, Modern Institute of Pharmacy. Nitin Deshmukh, sir. Rakesh Punasia, sir, who will be judging today's session. Today, this conference, the recent years, I have seen that our students have much inclination towards clinical trials and pharmacovigilance. So that was the motto behind keeping this conference topic and as clinical trials, because we pharmacists have a very great role to play when it comes to clinical trials. And the topic which we selected is very good. It means we have got so much registrations in that. Close to 1,000 registrations are there for our conference, and 300 are there in this campus, and remaining are through online. So we were not having that accommodation to accommodate more students, so that's why we kept it in a hybrid mode. And making this conference a really global conference, we have the delegates from USA, we have the delegates from UK, Denmark, Belgium, Malaysia, Sri Lanka, making this conference a really a global conference. And all of them are, I think, they are watching it live because this is streaming live through YouTube. And I welcome all the delegates also to this conference who are, I think the time difference will be there, but still they will be making it, I think. And I welcome all the delegates from outside India also. And last, not the least, my dear students, and all the delegates from different pharma institute in Indore and nearby places, I welcome you all. And I am sure that today will be a very awakening session for you, the two sessions which are going to be delivered by Ms. Bethany and Ms. Alice. And I'm sure that you will be very glad to hear from them. Thank you. And lastly, before I conclude, it will be not worth if I don't acknowledge my faculty members who have done very remarkable job from past 1 month. They are trying their best. They are keeping all the boxes ticked before this function begins. And I thank you all my teaching staff for making this occasion so graceful. And the support, non-teaching staff will always be behind the scenes, but without their support and blessings, we can't do this program in the way it has been. Thank you, my non-teaching staff, my students, and all the volunteers who have done. Words will be very less. To express my thanks to Sanjeet Yadav sir, who has been there with me for day and night to make this conference successful. He has been there for night, 2 o'clock also. He was working for this conference. I thank Atul sir and Sugandhi sir for giving us this wonderful campus to host this seminar. And thank you, sir, Nitin Mishra sir, Suren Tiwari sir, Sanjay Chauhan sir, Deshmukh sir. I thank you everyone for giving us the support for the organizing thing. Thank you everyone. Have a wonderful day. And wish you all, as we are, good festivals are coming up. I wish you all a happy Gudi Padwa and Eid for coming days. Thank you.
Thank you, sir, for the welcome address.
It is both honor and privilege to invite Dr. Bethany to share their insight and experience as for today's conference. Ma'am, please come.
First off, thank you everyone for coming, and it is quite an honor to be invited to this conference. When I first heard about it, many of you guys actually just saw the video, and I wanted to ask how many have actually been to the previous conference? A few of you? Okay. So the rest of you that saw that video, one of them had blonde curly hair, Mary Farrell, and that's actually how both Dr. Lee and I actually got invited to this conference. And so I wanted to take a step back and just reflect on my experiences as a pharmacy student going into become a pharmacist. In the United States, there's about 130 pharmacy schools, and every year about 14,000 students graduate. Those students go on to practice. They go into many different fields, and just similar to India, pharmacy is very diverse, and so you end up going into many different worlds. And so that was my perspective going into pharmacy school. It felt large, it felt vast, and I honestly felt like a fish in the sea. And when you get down to it, you start to realize a lot of people in the field just keep saying, pharmacy world is so small. It's small, it's tiny. And as you go further and further into your career and further into your specialization, you realize how small it is. And some of the moments of connection and those networking moments that you meet people at school, at work, at conferences, those are those networking moments that you have. And it was one of those moments where I got to meet Mary Farrell, and she introduced me to Dr. Pillai. And I was fortunate to be able to come here. Even though I'm not an esteemed researcher, I'm more of a clinician researcher. I am quite honored. And the many hours that you've spent probably contacting Dr. Lee at odd hours for me, and I had to calculate, okay, what time is it in India? Is he still awake? Can I still talk to him? To be able to coordinate all of this. So thank you very much for your warm welcome and amazing hospitality. It goes beyond that. I was able to bring my fiance to this particular conference in India, so thank you everyone. Give him a warm welcome. And I hope you enjoy the conference.
Thank you, ma'am, for your insightful words.
It's our privilege to invite our chief guest to address the gathering, Dr. Neeraj Upmanyu. Dr. Neeraj Upmanyu, Professor and Pro-Vice Chancellor, Sage University, Bhopal, and serving as member of Central Council in PCI, New Delhi.
Sir has completed his M.Pharm and PhD from the Department of Pharmaceutical Science, Dr. H.S. Gore University, Sagar. He worked as a nominated member in Education Regulation Committee, Professional Pharmacy and Public Relation Committee, and Law Committee in Pharmacy Council of India, New Delhi.
An expert committee member with AICTE, UGC, and expert in NEC, NBA, International Accreditation Council. Sir is working closely with International Pharmaceutical Federation, Netherlands, in education planning in various national and international journals. Authored 5 national and 3 international books and 8 chapters, 10 patent and 1 international patent.
Sir is a member of various professional bodies like APTI, SCPI, International Pharmaceutical Federation, Netherlands, Indian Pharmaceutical Association, Commonwealth Pharmacist Association, London, UK. He was awarded with a travel grant from ICMR New Delhi and MPCST Bhopal for attending the international conferences, Netherlands.
He is reviewer in various journals like European Journal of Medicinal Chemistry, Acta Pharmaceutica, African Journal of Pharmacy and Pharmacology, Drug Development and Industrial Pharmacy, Indian Journal of Pharmaceutical Science, and many more reputed journals.
An oft-decorated academician, Professor Upmanyu has been awarded with the Principal of the Year Award by Association of Pharmacy Profession, Dynamic Pharma Leader Award by APTI, Nirari's Excellence in Pharmacy Profession Award by Nirari Prakashan.
We are eagerly waiting to hear from you. Please give a loud applause as we invite Neeraj sir to say a few words for this conference.
So, Suprabhat, happy morning. Suprabhat. Good. So, guest of honor of today's function, Professor Singhvi sir, who is also my senior, chairman of this Jawaharlal Nehru Society, Honorable Arun Yadav sir, speakers from various countries, Miss Lee and Miss Bethany, my very good friends and professional colleagues, Atul Shirkhedikar sir, Nilesh Malviya sir, Sapna madam, and all my respected teachers, my very good friend, and we are always discuss a lot about pharmacy, and I really appreciate him, the principal of this GRY Institute of Pharmacy, Professor Pillai sir, and last but not the least, my dear students. Greetings on this second international conference on behalf of my own and behalf of Pharmacy Council of India. And I am really grateful that GRY Institute of Pharmacy has invited me on this second international conference for the much needed theme, that is clinical trials addressing practices, challenges, and global innovations. I must say, this is by chance or this is by destiny. This is the right time that this topic has been selected. I must say for this institute first, quality is not by chance, it is imbibed. You can see very abruptly in GRY Institute of Pharmacy whether we talk about the staff or we talk about the students. So I really appreciate principal sir, management and all that faculty members that you are doing a tremendous job. Now coming to the topic, I must say this is the right time we are discussing these clinical trials. Last 2 days I went in Delhi, and I am really glad to share that now Pharmacy Council of India is coming with new scheme and syllabus as per National Education Policy 2020. So now the students who will come after this year, they will study that syllabus. And now B.Pharm itself will be specialized after 2 years. एक बच्चा अगर इंडस्ट्री फार्मेसी में जाना चाहता है, एक बच्चा अगर क्लिनिकल फार्मेसी में जाना चाहता है, तो उनके लिए अब बहुत सारे ऑप्शंस होंगे. एंड क्लिनिकल फार्मेसी विल बी वन ऑफ द ऑप्शन आफ्टर 2 years. तो ये एक आप लोग के लिए एक बहुत बड़ी अपॉर्चुनिटी है जो फार्मेसी कर रहे हैं, कि वो अब उनके पास एक ऑप्शन रहेगा. क्या वो एक जनरल बी फार्मेसी के सिलेबस को चुनना चाहते हैं, क्या वो एक इंडस्ट्रियल फार्मेसी की तरफ जाना चाहते हैं, और एक और एरिया जिसमें इंडिया बहुत टाइम से मेहनत कर रहा है वो है क्लिनिकल फार्मेसी. तो अब स्टूडेंट्स के लिए एक बहुत बड़ी अपॉर्चुनिटी रहेगी. So I am really happy to share on behalf of Pharmacy Council of India, yes, we are coming with the new syllabus, and it will be a specializations kind of syllabus which the student can opt. Student के पास option रहेंगे, and at the same time higher education institutions के पास भी options रहेंगे कि वो 25% अपने courses को भी बच्चों को prescribe कर सके, क्योंकि क्या है, इंडिया की जो भौगोलिक conditions हैं वो बहुत different हैं. खरगोन में आपके पास संभावनाएं और अपॉर्चुनिटीज और करने का जो एक स्पेसिफिकेशंस है वो अलग है. इंदौर में अलग है, भोपाल में अलग है, ग्वालियर में अलग है, और ऐसे ही अगर महाराष्ट्र में देखें तो मुंबई में अलग है, शिरपुर में अलग है. तो इसको ध्यान में रखते हुए 25% की लिबर्टी अब इंस्टीट्यूट को दी जा रही है कि वो अपने हिसाब से इलेक्टिव्स चुने, अपने हिसाब से बच्चों को जहां पर लगता है जिस चीज की जरूरत है. जैसा सर ने बोला सुबह गैप एनालिसिस के हिसाब से इंस्टीट्यूट वो कोर्सेज प्रोवाइड कर सकता है अपने बच्चों को. अब आते हैं कि इस टॉपिक की महत्वता क्या है. बहुत अच्छा टॉपिक है क्लिनिकल ट्रायल्स का. व्हाट आर द प्रैक्टिस चैलेंजेस एंड व्हाट द ग्लोबल इनोवेशंस आर. इसके बारे में मैं सिर्फ आपको 3 ही चीजें बोलूंगा बिकॉज आई हैव स्टिपुलेटेड टाइम. कोई बच्चा बता सकता है कि एक ऐसी घटना जो फार्मेसी प्रोफेशन में हुई हो और जिसमें फार्मेसी के क्लिनिकल ट्रायल और फार्मेसी के ऑब्जर्वेशंस का बहुत इंपॉर्टेंट रहा हो, और जिसके लिए एक बंदे को यूएस का सबसे सर्वोच्च नागरिक सम्मान दिया गया हो. किसी ने पढ़ा हो फार्मेसी स्टूडेंट्स ने? तो किसी ने भी? चलिए मैं आपको क्लू देता हूं। आप सब लोग अपनी फार्माकोलॉजी में पढ़ते होंगे थैलेडोमाइड ट्रेजेडी। आप पढ़िएगा, आप सर्च कीजिएगा। कैलसी एक ऐसी वुमेन थी जो यूएस एफडीए के साथ स्टैंड करी। ये एक ड्रग थी जो मॉर्निंग सिकनेस में दी जाती है, और बिकॉज ऑफ द मिस इंटरप्रिटेशन ऑफ द ड्रग दिस थैलेडोमाइड ट्रेजेडी कम्स। तो ये एक ऐसा विषय है जिसमें आप सोचिए कि एक फार्मासिस्ट को यूएस का सबसे सर्वोच्च नागरिकता सम्मान दिया गया। एक और पर्सन जिसमें आप लोग सब लोग महेंद्र सिंह धोनी को बहुत अच्छे से जानते हैं ना? वेरी गुड। अमिताभ बच्चन को सब लोग जानते हैं। किसी ने चिलुगुरी परमात्मा का नाम सुना है? किसी ने कभी सुना हो चिलुगुरी परमात्मा? सोचिए, एक क्लिनिकल फार्मेसी का इंटरप्रिटेशन, एक सिंपल नॉलेज रखने वाला आदमी कितना आगे बढ़ सकता है। एक छोटा सा शहर है आंध्र प्रदेश में, नालागुंडा। वहां पर एक छोटा सा मेडिकल स्टोर चलाता है वो बंदा जिसका नाम है विजय मेडिकल। मैं हमेशा अपनी स्टोरी में जरूर बताता हूं, उसका नाम जरूर डिस्क्राइब करता हूं। उस बंदे ने, आप में से किसी ने कभी सुना हो, जिनका भी क्लिनिकल फार्मेसी में इंटरेस्ट आओ, मेडिकल काउंसिल ऑफ इंडिया जो अब एनएमसी बन गई है, एक नोटिफिकेशन निकाला था, गवर्नमेंट नोटिफिकेशन। डॉक्टर्स जितने भी ड्रग्स को प्रिस्क्राइब करेंगे वो कैपिटल लेटर्स में ही करेंगे। किसी ने सुना? किसी बच्चे ने? कैपिटल लेटर में नोटिफिकेशन था, और उसके पीछे जो आदमी था वो एक डिप्लोमा फार्मेसी वाला आदमी था जिसका नाम था चिलुगुरी परमात्मा, जिसके दोस्त की एक ट्रेजेडी के कारण उसने चीजों को समझा, चीजों को जाना, और चीफ मिनिस्टर से लेके, हेल्थ मिनिस्टर से लेके, स्टेट के प्रेसिडेंट ऑफ इंडिया से लेके वो फाइनली सुप्रीम कोर्ट गया, और सुप्रीम कोर्ट में वो जीता। और उसने एक उसके रिकमेंडेशन पर ये डिसाइड किया गया कि ड्रग्स अब कैपिटल लेटर्स में लिखी जाएंगी। तो एक डिप्लोमा फार्मेसी स्टूडेंट जिसको अब ऑस्ट्रेलिया और अमेरिका में भी इनवाइट किया जाता है एड्रेस के लिए। सो दैट इज हाउ द पावर ऑफ अ फार्मेसी इज, और फार्मासिस्ट इज, इफ यू अंडरस्टैंड द क्लिनिकल इंटरप्रिटेशन। एक और इंपॉर्टेंट चीज है जो आगे आने वाले समय में स्टूडेंट्स के लिए बहुत इंपॉर्टेंट है, वो है कि अमलगमेशन ऑफ टेक्नोलॉजी। अगर हम क्लिनिकल ट्रायल्स की बात करें, अगर हम इनोवेशंस की बात करें, एक और एग्जाम्पल, ब्यूटीफुल एग्जाम्पल, आप सब लोग नेट पर सर्च कीजिएगा। एक बड़ा अच्छा बच्चा है जिसको आप सर्च करेंगे अभी, जैक एंड्रा का। आपको विश्वास नहीं होगा, 15 साल की उम्र में उस बच्चे ने पैंक्रेटिक कैंसर को डिटेक्ट करने की किट को आविष्कार कर दिया 15 साल की उम्र में, जिसमें हम सिलेबस को जस्ट सेंटर करते हैं कॉलेज में और समझने की कोशिश करते हैं 15-16 साल में। उस बच्चे ने, नाउ ही इज परस्यूइंग हिज मैकेनिकल इंजीनियरिंग फ्रॉम यूएस, और हाउ वंडरफुल दैट गाय इज। तो दिस इज हाउ योर इनोवेटिव अप्रोच इज। यू हैव टू अंडरस्टैंड द एस्पेक्ट्स ऑफ क्लिनिकल फार्मेसी, you have to understand the amalgamation of technology, whether it is MI, whether it is data analytics. आपको समझना पड़ेगा कि डेटा को भी कैसे इंटरप्रेट करना है। If you will understand what data interpretation is, what pharmacovigilance is, what kind of requirements in clinical trials is, then you can, carry out the things in a correct manner. और उसके लिए मेरा जो खुद का परसेप्शन बोलता है, अभी भी इंडिया के अंदर क्लिनिकल फार्मेसी, क्लिनिकल ट्रायल्स और क्लिनिकल एप्लीकेशंस को समझना बाकी है। तभी हम बात कर पाएंगे, यस, इंडिया हैज बीन इम्प्लीमेंटेड हॉस्पिटल फार्मेसी इन फुल फ्लेज्ड मैनर। तो आप सब बच्चों को भी जो फार्मेसी कर रहे हैं, इनको ये समझना पड़ेगा कि what are the major requirements in clinical trials, what pharmacy practices required from us, then we can establish ourselves. Now it is, you all know कि PharmD को भी अभी रिकॉग्निशन मिली है एज ए क्लिनिकल फार्मासिस्ट। तो ये सब चीज़ें आपको समझनी भी पड़ेंगी और इनकी रिक्वायरमेंट्स को समझना पड़ेगा। पिछले दिनों मैं परसों दिल्ली में था, जब इस सिलेबस पर डिस्कस कर रहे, तो CDSCO की तरफ से आया। मैं हर बच्चे से रिक्वेस्ट करूंगा, CDSCO की वेबसाइट, मिनिस्ट्री ऑफ हेल्थ की वेबसाइट्स, क्या चल रहा है मेडिकल डिवाइसेस में, उसकी वेबसाइट, इन सबको भी जरूर पढ़ें, क्योंकि आप सब तो टेक्नोलॉजी वर्ल्ड वाले बच्चे हो, हम लोग की तरह नहीं हो जो गांव से पढ़े हुए हैं। तो आप इन चीज़ों को समझो और अपनी अवेयरनेस को क्रिएट करो, देन यू कैन बी सक्सेसफुल. वंस अगेन आई थैंक सुजीत पिल्ले सर, management of GRY Institute of Pharmacy and all the faculty members for inviting me and providing me this opportunity. आपके साथ अभी अतुल शिरखेड़ीकर सर भी हैं, नीलेश मालवी सर हैं, इनके लेख पढ़िए आप, बहुत अच्छे लेख हैं. सपना मैम इज अ ग्रेट स्पीकर. तो आप इन सबको सुनिए, इनसे बात करिए, then you can understand where the pharmacy is going. I am thankful to all the staff members for inviting me and providing me this opportunity. Jai Hind, Jai Bharat. Thank you so much.
Thank you so much, sir, for your invaluable words. It's our honor to have Dr. Indrajit Singhvi, sir, as a guest of honor today. Dr. Indrajit Singhvi, Provost at Pacific Medical University, Udaipur, Rajasthan. He earned his degree from BN College of Pharmacy, Udaipur in 1991 and secured second position at Rajasthan University level in the first batch. He is a gold medalist of 1994 batch in his Masters of Pharmacy in DAVV Indore and completed his doctorate in 2000 from DAVV Indore.
Sir began his career as production officer from Cipla Limited, Mumbai. Then he joined as research associate in Ranbaxy Lab Limited at Devas. Later, Sir has joined academics in 1995 and held various positions from lecturer at BN College of Pharmacy, associate professor at Department of Pharmacy, ML Sukhadia University, Udaipur, Dean Pharmacy at Pacific College of Pharmacy, Vice Chancellor at Sai Tirupati University. Sir has published more than 250 research papers and review articles in reputed national and international journals, published 4 books.
We kindly request Dr. Indrajit Singhvi, sir, to grace the stage and share their valuable thoughts. Please join us in welcoming him with a huge round of applause.
Good morning, everybody. Respected Yadav sir, Chairman, JNCET, my dear Sujit Pillai, first research scholar of mine, whom I am proud of after completion of PhD of his around 20 years back. Most sincere personality I have ever encountered. Dr. Upmanyu sir, very good friend of mine, a great pharmacist with great contribution in the profession. Honorable speakers, Dr. Carpenter from USA and Miss Ellie from Taiwan. Dear faculty members, registered delegates for this conference, and my dear friends, students. First of all, I would like to thank the management, JNCET, and GRY Institute of Pharmacy for giving me this opportunity to share the dais with galaxy of eminent personalities. Really, this day will be remembered for long, being sharing a dais with these amenities. When I received a call from Sujit that there is going to be an international conference and I am supposed to be here, not a second thought was possible for me, because when he has accepted 100 requests of mine, it is my duty to accept at least one request of his. So I am here in front of you. Very beautiful campus. I have been associated with several universities and was instrumental in developing few of the universities, establishment of few of the universities at Udaipur. Very beautiful campus, and I came to know that the campus is going to be a university soon. So my all best wishes are with you, Yadav sir. And I assure you, you can, if you think that I can be of any help ever for your university, at personal level or professional level, please do inform me. I will try to help you out to whatsoever bit of knowledge I have gained in 30 years of my professional life and around 15 years of administrative life. So I always will be there, and I am very much confident that soon you will get the status of an state private university. Definitely that do have some very, very good advantages if you want to take it. There are two sides of coins. It depends which side you are choosing. To start with, I just would like to elaborate what Upanyu sir has told. We need to go back pertaining to this conference on clinical trials. As sir has told, we need to go back in late 1950s and early 1960s, specifically 1961, when this thalidomide tragedy took place, wherein, as sir has told, few pregnant ladies were given thalidomide just to treat morning sickness. But later on, when data were collected of the babies born out of those pregnant ladies, it was found that the limb part was missing or it was deformed in the babies which were given birth by the mothers who were given thalidomide. Even to the extent that the second and third generation of those ladies who have taken thalidomide were having these deformities. So what was the reason for that? This is simply because the clinical trials of that drugs was not carried out properly. Specifically, phase 4 trials were not carried out properly. And that led to teratogenicity. The word in pharmacology is teratogenicity. So these were teratogenic side effects of the thalidomide. Later on, just we have seen the corona pandemic vaccine. I have taken 3 doses. Because I was with medical college, I was with the first person who has taken first dose, second dose, and booster dose. Was a privileged person for that. But still, some of the researchers think, I don't know whether they are right or wrong, but some of the researchers think that few of the side effects, that is, induction of diabetes in non-diabetic persons, some heart attacks, hazelness when you are climbing some stairs. These are the side effects pertaining to corona vaccine. I don't have any authenticity of that, but whatsoever I have read. So that may be because of the massacre that was going on that days. It was very necessary for the government to introduce a vaccine, and maybe some phases of the toxicity studies were not carried out. Because of that, some of the side effects are reflected. But depending on the situation of the country that time, that was necessary to introduce. So corona has also given us an insight that how a clinical trial are important to us. Yes, today 2 experts we have in this conference. They definitely will enlighten you on various aspects, global aspects, because both are international speakers. So they will enlighten you about the global aspects of clinical trial. Madam, I think there are few aspects which are supposed to be enlightened. The problem that clinical trials are facing these days can be divided into several parts. The first aspect being selection of a proper patient for clinical trial and retention of that patient. They start clinical trials, but because of the complications of clinical trials, most of the persons who are involved in clinical trials are abstaining themselves from those clinical trials. In between, that creates a massive problem for the persons who are carrying clinical trials. Then inclusivity and exclusivity of the persons who are to be included, who are to be taken for clinical trials. That definitely is a problem. That definitely is a criteria which has to be taken care of very cautiously. The diversity of the population, of the subjects the person has chosen for clinical trials, That is from maybe if somebody has taken clinical trials in US, it may so happen that that is not that much effective in India. Even to the extent that if we have taken the subjects from Rajasthan, then it may so happen that because of the diversity, those data are not that much effective for Tamil Nadu. So diversity of the population subjects which are for clinical trials is to be taken care of. I think the experts will enlighten on that. Then there are certain regulations of the regulatory bodies, FDA and all type of regulatory bodies. Those restrictions are to be taken care of. Definitely they prepare their regulation so as to safeguard the power, the rules, the rights of the person taking care of taking part in the clinical trial. So those definitely are constraints. The cost of clinical trials is very high, how to reduce that. And the data handling of clinical trials is a big problem. However, in today's scenario, few of the technologies have evolved. Recent technology is artificial intelligence. So application of artificial intelligence in clinical trials is to be explored extensively. Because artificial intelligence can give you an idea of designing and protocol. A perfect idea of designing and protocol. Maybe when you are preparing a protocol for clinical trial, you might be missing few points. So help of artificial intelligence can be taken care of, wherein it will suggest that these parameters are to be included for this specific clinical trial. Even to the extent that telemedicine and the mobile technology will make it somewhat easier for data collection if the patient or the subject who is taking part in the clinical trial, he may be at his home, he is not supposed to come to the hospital daily for collection of data by telemedication and by mobile and by the apps of clinical trials. He can upload the data on a mobile app and those can be utilized. I think, lastly, I would like to just maybe a suggestion or maybe experts will elaborate on that. There shall be a consortium between a pharmaceutical company, between academic institution, which includes pharmacy institute and a medical institute and a nursing institute, paramedical institute, because all have to work collaborative for clinical trials. So a consortium shall be prepared for pharmaceutical industries, for academic institution and the regulatory bodies. The persons from all these three should sit together and shall share the data so that a proper clinical trial protocol can be prepared and the proper conclusions of the clinical trials can be come out. So best wishes for this one-day conference. And I think whatsoever outcomes are there from the experts from Taiwan and USA, and the local experts available over here, those will be confined to a booklet, but those will be communicated to the regulatory bodies and the authorities who are responsible for taking care of the rules and regulations for the clinical trials. Even if 2-4 suggestions can be implemented, that will reflect the success of this conference. Again, I would like to thank the management, very beloved student and friend, now not a student, a friend of mine, Dr. Pillai, and all of you for giving me a patience listening. We'll hope that we'll come across, will interact with you in a personalized manner at GRY College of Pharmacy someday, so that we can exchange the ideas in an elaborative form whenever given chance. Thank you. Thank you very much.
Professor Singhvi's advice to youth is not to believe in shortcuts for success, but to think of long-term gain and put in hard works.
Thank you so much, sir, for your insightful and thought-provoking words.
It's our honor to introduce a visionary leader and the driving force behind our institution's success, coming from a farmer's family. Arun sir is an academician, industrialist, businessman, and well-known politician.
Sir is the chairman of JNCET GBYST group of institutions, chairman of Cooperative Sugar Mill and Spinning Mill. Sir is managing director of Nimar Motor, having dealership of Maruti Arena, Maruti Nexa, Hero Honda, Force Motor and Teffe Tractors.
Sir has a deep interest in farming and still continues his passion in farming by bringing new and innovative ideas to improve the productivity in farming. Sir is also a permanent member of Bharat Krishak Samaj, New Delhi.
Politically, he is an active member of Indian National Congress, and formerly, Sir was the president of MPCC, Central Minister, holding various positions as Sports and Youth Welfare Minister, Heavy Industry and Public Enterprises Minister, Agriculture and Food Processing Minister.
Please join us with a loud applause to hear from our chairman, Sir. Sir, please come for a vote of thanks.
आज के इस बहुत ही महत्वपूर्ण और इंटरनेशनल कॉन्फ्रेंस ऑन क्लिनिकल ट्रायल्स एड्रेसिंग प्रैक्टिसेस चैलेंजेस एंड ग्लोबल इनोवेशंस हमारे आज के चीफ गेस्ट डॉक्टर नीरज उपन्यु, हमारे विशेष अतिथि आदरणीय इंद्रजीत सिंघवी जी, ऑन बिहाफ ऑफ GRY Institute of Pharmacy, I would like to welcome Dr. Bethany Carpenter from California, USA, Miss Alice from Taipei, Taiwan. It's our honor to invite you for this international conference here. Once again, I would like to welcome both of you for this very important conference. And I've requested them, next time you are here, you have to be here for at least 10 days. हमारे आज के विशेष अतिथि डॉक्टर सपना मालवी जी, नितिन देशमुख जी, डॉक्टर राकेश पुनिया जी, अंकित शर्मा जी, हमारे GIT के प्रिंसिपल अतुल उपाध्याय, डॉक्टर सुगंधी, डॉक्टर आशीष, यूनुस खान, देशमुख जी, मिश्रा जी, बहुत सारे हमारे पेरेंट्स भी यहाँ आए हैं, उन सबका भी मैं अपनी ओर से, संस्था की ओर से स्वागत करता हूँ. एंड माय डियर स्टूडेंट्स एंड टीचर्स, नीरज जी, हम लोग ये इंस्टीट्यूट को पिछले 27-28 सालों से लगातार चला रहे हैं और मुझे बहुत खुशी है आप सबसे ये बताते हो. वैसे तो अतुल ने आपको सुजीत ने बताया होगा. And especially for the speakers, our institute is only institute in my state to get autonomous body recognition, and only institute in Madhya Pradesh in my state to get a NEC accreditation also. So इसके लिए सुजीत, टीम GRY और सभी स्टूडेंट्स को मैं बहुत बहुत बधाई, शुभकामनाएं देता हूं. और जो हमारे पेरेंट्स यहाँ पर आए हैं बच्चों के, उनको कहना चाहता हूं कि मध्य प्रदेश में हमारा इंस्टीट्यूट, अब मैं कह सकता हूं नीरज जी कि टॉप 5 में ज़रूर होगा. मैंने इसका एनालिसिस तो नहीं कराया, लेकिन मैं नीरज जी से ज़रूर कहूँगा और इंद्रजीत जी से भी कहूँगा कि आप इसका एनालिसिस ज़रूर करें कि हमारी स्टैंडिंग आज की तारीख कहाँ पर है। और मुझे उम्मीद है कि जिस तरह से हमारी फार्मेसी की टीम लगातार नए इनोवेशंस की ओर काम करती है, एंड दिस इज नाउ सेकंड कॉन्फ्रेंस, इंटरनेशनल कॉन्फ्रेंस, यू मस्ट हैव had the screenshots there। 22 में हमने ये कॉन्फ्रेंस किया था और अब फिर 25 में इंटरनेशनल कॉन्फ्रेंस करने का मौका मिला। इस विशेष कॉन्फ्रेंस के लिए मैं अपनी ओर से जो हमारे स्पॉन्सर्स हैं उनको भी बहुत धन्यवाद देना चाहूँगा। बोर्ड ऑफ रिसर्च एंड न्यूक्लियर साइंस मुंबई। So we have 4 sponsors for this conference. So who have helped us to organize the conference in our institute. Council of Scientific and Industrial Research, CSIR Delhi, Madhya Pradesh Council of Science and Technology Bhopal। ये सबके बहुत अथक प्रयासों से, सहयोग से हम लोगों को इस कॉन्फ्रेंस में बैक सपोर्ट मिला है, फाइनेंशियल सपोर्ट मिला है। मैं सुजीत को कहूँगा कि जो हमारे स्पॉन्सर्स हैं उनको विशेष धन्यवाद पत्र के माध्यम से मेरी ओर से आप ज़रूर भेजें। और हमारे बीच में डॉक्टर नीरज उपमन्यु जी आए हैं, आपने उनके बारे में इंट्रोडक्शन में सुना होगा। मैं बच्चों से कहना चाहता हूँ, डॉक्टर इंद्रजीत उदयपुर से हमारे बीच में आए हैं। दोनों अपने फील्ड के मैं कह सकता हूँ महारथी हैं और ब्रॉड नॉलेज, पिछला एक्सपीरियंस 25-30 सालों का विशेष और अनेक पदों पर फील्ड में, अपने फार्मेसी के फील्ड में रहने का उनको अवसर मिला है। हमारे जो काउंसिल है उसके मेंबर हैं डॉक्टर नीरज, तो ये हम सब के लिए बहुत गर्व की बात है। थैंक यू नीरज जी और इंद्रजीत जी कि आपने अपना विशेष समय सुजीत के एक इनविटेशन पर यहाँ पर आप पहुँचे। उदयपुर से चलकर आए हैं, भोपाल से चल के आए हैं। एंड आवर स्पेशल गेस्ट फ्रॉम USA, हाउ मेनी आवर्स इट टुक यू टू कम टू इंडिया? फ्लाइंग टाइम 26 hours? Yeah, almost 26 hours. And for you, Alice? 10 hours. So 26 घंटे हवाई जहाज में बैठकर और दूसरी 12 घंटे हवाई जहाज में बैठकर, और डॉक्टर इंद्रजीत जी ट्रेन से चल कर आए 12 घंटे, और नीरज जी बाय रोड पहुंचे हमारे बीच में 6 घंटे लगा के। तो मैं ये कहना चाह रहा हूँ विशेष रूप से स्टूडेंट से कि जो आज की कॉन्फ्रेंस है इसको बहुत तन्मयता से, मैंने देखा बहुत सारे लोग बाहर घूम रहे थे, अभी घूम रहे हैं तो उनको अंदर बुला लीजिए। आफ्टर जो नेक्स्ट जो सेकंड सेशन हमारा होगा, एंड जो टॉपिक चूज़ किया है नीरज जी ने भी बताया कि इट इज़ वेरी हैपनिंग नाउ डेज, वेरी इंपॉर्टेंट टॉपिक जिसको लेकर देश विदेश में, विश्व भर में मेडिकल साइंसेस काम कर रही है। वो टॉपिक पर हमें इंटरनेशनल कॉन्फ्रेंस ऑर्गेनाइज करने का मौका मिला, ये हम सब के लिए बड़ी गर्व की बात है। और मैं तमाम विद्यार्थी स्टूडेंट साथियों से कहूँगा कि वो इसका जो टेक अवे है वो उसको बहुत तन्मयता से सुने, उसका रिसर्च के बारे में पढ़े। एक बहुत अच्छा सुझाव नीरज जी ने यहाँ पर दिया है कि बहुत अनेकों वेबसाइट्स हेल्थ मिनिस्ट्री की आजकल अपलोड होती है, जिसमें हम लोग बहुत सारे इश्यूज, बहुत सारे प्लेटफॉर्म्स पर अनेक प्रकार की जानकारियाँ उपलब्ध कर सकते हैं। थोड़ा व्हाट्सएप कम चलाना है, थोड़ा इंस्टाग्राम कम चलाना है, थोड़ा चैट कम करनी है, और जो समय अपने घर पे मिले कंप्यूटर पर, उसमें इन हेल्थ मिनिस्ट्री की वेबसाइट पर जाकर रिसर्च करने का कोशिश हमको करना चाहिए। सुजीत, हमारे रिसर्च पेपर स्टूडेंट्स को लिखते हैं, कितने लिखते हैं?
हर साल कम से कम 25 पेपर आते हैं।
कितने होना चाहिए आपके हिसाब से नीरज जी? ज़्यादा होना चाहिए, मैं तो कहता हूँ सबका एक होना चाहिए। सो अगर 25 रिसर्च पेपर लिखे जा रहे हैं तो आई वुड लाइक कि उसको इस साल सुजीत डबल करेंगे, मैं उम्मीद करूँगा। और हमारे जो अतुल और सुगंधी जी यहाँ बैठे हैं, बड़ी हाई होप्स संजीत मुझे इन लोगों से है मैं उम्मीद करूंगा कि देशमुख जी इसी तरह के इंटरनेशनल कॉन्फ्रेंस इंजीनियरिंग की भी और दूसरे इंस्टीट्यूट्स की भी यहाँ हो, जिसमें दोबारा हम नीरज जी को और इंद्रजीत जी को बुलाएंगे। और उम्मीद करूँगा कि आप सब लोग बहुत इसको अच्छे से सुनेंगे, लिखेंगे, पढ़ेंगे। और ये प्राउड ऑनर है हम लोगों के लिए, स्टूडेंट्स के लिए, कि जो भी यहाँ फर्स्ट ईयर में होंगे या सेकेंड ईयर, थर्ड ईयर, फोर्थ ईयर के हैं, कि उनके रहते हुए यहाँ पर ये कॉन्फ्रेंस ऑर्गेनाइज की गई, इंटरनेशनल कॉन्फ्रेंस ऑर्गेनाइज की, जिसका स्ट्रीमिंग ऑनलाइन लाइव चल रहा है। और ग्लोबली अनेक देशों के जो पार्टिसिपेंट्स, ऑलमोस्ट मोर देन 1000 से ज़्यादा लोग लाइव इस इंटरनेशनल कॉन्फ्रेंस को सुन रहे हैं, देख रहे हैं। सो ये हम लोगों के लिए बड़ी ऑनर की बात है। मैं फिर से अपनी ओर से नीरज जी को, इंद्रजीत जी को और दूसरे जो हमारे गेस्ट आए हैं, जो नेक्स्ट सेशन के लिए यहाँ पर पार्टिसिपेट करेंगे, उन सबको इंस्टीट्यूट की ओर से, अपनी ओर से, काउंसिल की ओर से बहुत बहुत उनका स्वागत, अभिनंदन और उनका धन्यवाद भी करता हूँ। और इंद्रजीत जी से मैं बात कर रहा था कि जहाँ वो काम करते हैं वहाँ पर 4 मेडिकल कॉलेज हैं। तो जो हमने एक एजेंडा हाथ में लिया है कि इसी बोराव गांव में मेडिकल कॉलेज भी खोलें, तो उस पर और हम लोग अग्रसर हैं। और प्राइवेट यूनिवर्सिटी की भी हम लोग लाइन में लगे हुए हैं। नीरज जी, कोशिश, उम्मीद है कि सरकार हमको जल्दी ही उसकी परमिशन देगी। सो नाउ दिस विल गोइंग टू बी अ प्राइवेट यूनिवर्सिटी इन कमिंग डेज, near future, maybe in a year or so. Maybe next time you are here, then we are a private university. And then again we are going to be we are trying for a medical college also. So maybe next time we call you as a speaker for the medical college also. So once again I thank Miss Alice, Dr. Bethde, and what's your name? So I have not, what's the name of your friends? Richards. So I would like to welcome Richards also. On behalf of my team, and I would request next time, you're here for a very short visit this time, so next time you should come for a longer period. So India is very happy, I must say. So we are a country of 29 states now, different vast cultures and number of languages we speak here. So you must come with your family next time and visit India, stay here for some more time, few days, and explore what India is doing. Now we are going to be a third largest economy after USA. So, and I as a proud Indian, I must say, in IT, we are number 1. So IT sector में, software development में, हम विश्व में नंबर 1 पर हैं। सारे देश, विश्व के, ग्लोबली सारे देश के कंप्यूटर चलाने वाले लोग हिंदुस्तानियों से काम कराते हैं। तो ये हम लोगों के लिए बहुत एक प्राउड है, हमारे देश के लिए। वी शुड बी प्राउड ऑफ दैट कि इंडिया इज नाउ नंबर 1 इन IT। एक ज़माने में नीरज जी बता रहे थे कि उनके समय ना तो कोई ऑनलाइन था, ना कोई इंटरनेट था। हमारे ज़माने में शायद इंटरनेट, अतुल जब हमने शुरू किया था यहाँ कुछ भी होता नहीं था। 99 में जब हम यहाँ आए थे नीरज जी, जब ये इंस्टीट्यूट शुरू किया था, एक गोडाउन में शुरू किया था। एक गोडाउन था कपास का, हमारी स्पिनिंग मिल हुआ करती है। तो उस गोडाउन में हमने 96 में इंजीनियरिंग कॉलेज शुरू किया, जब अतुल उपाध्याय भी वहाँ होते, संजीत भी होते थे। इन 99 वी केम हियर विद स्टार्ट बिल्डिंग, बनाना शुरू किया हम लोगों ने। और अब दिस इज 31 ईयर्स नाउ, तो 30 साल ऑलमोस्ट हो गए गोडाउन से मेन बिल्डिंग में पहुंचने में हमें। सो बहुत सारे चीज़ों पर, इनोवेशंस पर, रिसर्च पर हम लोग काम करते हैं, हमारी टीम काम करती है। और हम लोग एक छोटा स्कूल भी चलाते हैं जिसमें करीब 1100-1200 बच्चे हैं, ओनली फॉर लोकल स्टूडेंट्स। और यहाँ वी हैव डिग्री कॉलेज, B.Ed, D.Ed है, फार्मा है, इंजीनियरिंग के। So we run almost 8-9 institutes here, Mr. Alice. So we have pharmacy, we have engineering, we have degree college here, we run a school for local children here. So from nursery to graduation, and for MD also we have seats here where the students can do the studies here. So ये एक नया काम हम लोग करने की कोशिश करते हैं। मैं एक बार फिर से सभी गेस्ट का बहुत बहुत अभिनंदन, स्वागत, और स्टूडेंट्स का जो यहाँ आए हैं, जो इसमें पार्टिसिपेट कर रहे हैं। बहुत सारे बच्चे स्कूल में भी हैं, वहाँ पे भी ऑनलाइन देख रहे हैं, GRY में भी देख रहे हैं। तो मैं आई वुड रिक्वेस्ट सुजीत कि जब कॉन्फ्रेंस के बाद गेस्ट को स्कूल कॉलेज की तरफ ज़रूर ले जाएं। आई वुड रिक्वेस्ट Miss Alice and Dr. Bethany, you must visit our college also before you leave this place. और एक बार फिर से आप सबका बहुत बहुत धन्यवाद। And you must carry a very important, what I was discussing in the morning. So this place is very famous for Maheshwari saris. So I would request Sujit कि डॉक्टर साहब को भी देना है, क्योंकि जब घर पहुंचे तो मैडम को पता होना जी कहाँ से आए हैं, ठीक है। सो इट विल बी अ बिग रिमेम्बरेंस फ्रॉम आवर साइड। और यहाँ जो महिलाएं बैठी उनको पता है कि महेश्वरी सारिस का कितना इम्पोर्टेंस हमारे इलाके में है। सो एक बार फिर से सबका बहुत बहुत धन्यवाद। और सुजीत, टीम फार्मा, स्टूडेंट्स, नॉन टीचिंग स्टाफ, सुन रहे हैं मेरी बात? पीछे बहुत सारे उधर बैठ के, हाँ, गुड। सबको बहुत बहुत धन्यवाद। आई एम वेरी इम्प्रेस्ड। मैं सुजीत को कहा कि बहुत अच्छे तरीके से और सिस्टमेटिक तरीके से हम लोगों ने इस कॉन्फ्रेंस को कंडक्ट किया है। मेरी बहुत बहुत शुभकामनाएं सबको। वंस अगेन डॉक्टर साहब, आप दोनों का थैंक यू वेरी मच फॉर कमिंग हियर। थैंक्स अ लॉट। जय हिंद।
Thank you so much, sir, for your word of thanks.
It is time for one of the most awaited moments, Subhash Yadav Memorial Award for the Student of the Year 2024, most prestigious award of GRY, with a cash prize of 11,000 and a trophy.
This award honors not only academic excellence, but also a leadership, dedication, and the spirit of perseverance. We request Principal Sir to announce the winner. Please welcome with a huge round of applause.
Hey. The Student of the Year, usually we would give it on annual function, but this year, because of very academic schedule is very disturbed this year because of RGPV examinations and all. We were not able to conduct our annual function because many of students have back-to-back exam, first year exam, second year exams and all. So we thought that this is a great stage to honor our student who has worked very hard for 4 years for this prestigious award. And what procedure we follow is that we will ask the student, we have a nomination form for that, and we will ask the students to fill it. And it is not very easy nomination form. Very few students will make up that form because they have research article publication in that, they have conference attended, they have what role they have played as a pharmacist, their academics, their sports, co-curricular, extracurricular activities and all. And this award is given on our founder chairman, on the memory of our founder chairman, late Shri Subhash Yadav ji. And may I request Arun sir to please do the honors to announce this award.
This is the Best Student Award for the year. Let me check. Any guesses? कोई बता सकता है क्या? जोर से बोलो यार, सुनाई दे रहा है। Any idea? Huh? Gaurav? एक ही है बस, एक ही है. हाँ, कौन सा? आवाज नहीं आ रही तुम लोगों, दम नहीं है तुम लोगों में. ओके, सो बेस्ट स्टूडेंट अवार्ड फॉर 24-25 24-25 B Pharma 8th semester goes to, कैसे मालूम तुम लोग, कैसे बताइए, किस टीचर ने बताया ये बताओ. ये तुम लोग किसने तुमको बताया ये मैं जानना चाहता हूँ. सुजीत, इनको कैसे पता चला ये कुछ तो गड़बड़ है, कुछ गड़बड़ है. किसने बताया इन लोग टीचर्स को? हाँ, क्या बोल रहे?
पेरेंट्स आए हो. पेरेंट्स आए.
मैं भी पेरेंट हूं, मैं भी आया हूं. बहुत सारे यहाँ बैठे हैं. ओके, सो रौनक यादव.
रौनक, प्लीज कम टू द स्टेज.
उनके पेरेंट्स को बुलाइए, पेरेंट्स को बुलाइए. थैंक यू सो मच. अगले साल सोचिए ज्यादा होना चाहिए ना, एक ही क्यों हो रहा है, मतलब और भी होना चाहिए इस तरह से. आइए आइए, कम कम.
Congratulations, sir.
As a token of our appreciation and gratitude, we would now like to present memento. This small gesture is a reflection of our respect and admiration for their valuable time, insight, and contribution today.
The memento, which is presented today, is deeply rooted to the Indian culture. The memento is prepared by tribals of Baitul region of Madhya Pradesh. We request Arun sir to present a memento to our respected chief guest, Dr. Neeraj Upmanyu sir. Thank you, sir.
We request Arun sir to present memento to our respected guest of honor, Dr. Indrajit Singhvi sir. Thank you, sir.
We request Arun sir to present a memento to our prominent speaker, Dr. Bethany Carpenter ma'am.
We request Arun sir to present memento to our esteemed speaker, Miss Alice. Thank you, sir.
Ladies and gentlemen, as we come together to celebrate the success of this conference, it is with a great pleasure that we unveil the official conference proceeding. This proceeding is a compilation of valuable research, discussion, and insights shared by the esteemed participant. It leaves a lasting record of knowledge and ideas exchanged during this event.
To mark this special moment, we now request Chief Guest, Guest of Honor, Arun Sir, and dignitaries to officially release the conference proceedings. Let's have a big round of applause as we unveil the proceedings.
Now we proceed with the signing of certificate for the official marking of this conference.
Finally, let's capture this wonderful moment with a group photograph. I request all the dignitaries to assemble for a photo session.
I request Nilesh sir, Sapna ma'am, Atul sir, please come on the stage. Atul sir, Sugandhi sir, my staff members, please come on the stage for. GRY staff members, please come on the stage for a group photograph. Richard, may I request you to please come on the stage.
As we move forward with the program, we kindly request everyone to gracefully occupy their seats of the dais.
To host the next segment of conference, we would like to call Mr. Prakhar Chaudhary and Vanshika Jaiswal.
Thank you.
Good afternoon, distinguished guests, esteemed speaker, and respected delegates. I am Prakhar Chaudhary.
And I am Vanshika Jaiswal.
It is an absolute honor to welcome you all in this prestigious international conference on clinical trials addressing practices, challenges, and global innovation.
We are delighted to have experts from around the world for joining us today to share their invaluable insights. Often, we see the final product, the polished presentation, and the final outcomes. But behind every achievement lies a story of dedication, hard work, and unwavering passion. We have a unique opportunity to see into the journey of Miss Alice ma'am.
This video is a visual chronicle of their path, the lesson learned, and the driving force behind her work. It's a chance to witness the essence of what makes her such an influential figure.
We are about to watch the video, so please direct your attention to the screen.
Proceed with the program, it is my privilege to invite our respected session chair, Dr. Atul Khedkar sir, and our respected speaker, Miss Alice ma'am, to kindly join us on the dais. Sir and ma'am, please come to the dais.
Ladies and gentlemen, we are now at a pivotal moment in our program as we prepare to welcome our speaker who has made significant contribution to pharmacy field.
To provide the proper context, may we have the privilege of inviting our session chair, Dr. Atul Khedkar sir. Please join us in extending a warm welcome to Miss Alice ma'am. Thank you so much, sir, for a warm welcome. We are truly honored to have such a brilliant expert among us.
To formally welcome our session chair, a great academician and researcher, Dr. Atul Khedkar sir, Vice Principal at R.C. Patel Institute of Pharmacy, Sirpur. We request Dr. Nikhilesh Birla sir to extend a floral welcome of our session chair. Please put your hands together.
Thank you so much, sir, for a warm welcome. Let's move on with the program. It is a privilege to introduce our respected session chair, Dr. Atul Khedkar sir.
Dr. Atul Khedkar sir currently holds the position of Professor, Vice Principal at R.C. Patel Institute of Pharmaceutical Education and Research in Sirpur. Sir is a prominent figure of academia.
He serves as the chairman of the Board of Studies and the member of Academic Council at Kavitri Bhinabai Chaudhary, North Maharashtra University, Jalgaon.
Sir has supervised the research of more than 75 MPharm students and guided 5 students for PhD.
His scholarly contributions are substantial, with over 175 research papers published in prestigious international and national journals. Sir has achieved an H index of 25 and received over 2,450 citations. Additionally, he has authored 6 books in the pharmacy field, contributed a 10-book chapter, and has also filed 4 patents.
Sir has received research grant of Rs 50 lakh from government funding agencies.
Sir has also received several honors for his contribution, including the Best Teaching Award in 2018-19 and the Research Excellence Award in 2020 and 2022 from KBC North Maharashtra University, Jalgaon. That's all about Atul sir.
Now, as we proceed, it is time to hear from our esteemed session chair, Dr. Atul Khetkar sir, who will share his thoughts to introduce our speaker, Ms. Alice ma'am, for this session.
With his vast experience and deep understanding of pharmacy field, Dr. Atul Khetkar sir is the perfect person to highlight the contribution and expertise of our honored speaker. May we request the session chair to introduce and invite our speaker for the session. Sir, please come.
Good morning, one and all. Welcome, respected madam, for this wonderful conference. I compliment the GRY Institute for organizing such wonderful the event or your international conference one. And my congratulations to all the faculty members for their hard work they have put over here, and also the management bodies to support them for organizing such a great and wonderful the event over here. I'm really honored to and delighted to introduce the today's eminent speaker, Ms. Lee, who is a clinical pharmacist specializing in the critical care at Wangfang Hospital, a leading medical center in Taipei, the capital of Taiwan. She provides the direct patient care in the intensive care units, collaborating with medical teams to optimize medication therapy and ensure the patient safety. Dedicated to education, Ms. Lee trains healthcare professionals on the latest advancement in critical care pharmacology. She is also the mentor pharmacy student and serves as a clinical instructor at both hospital and the university level. Ms. Lee has completed her Bachelor of Science in Pharmacy, Master of Science in Clinical Pharmacy, and PhD from Taipei University, Medical University, School of Pharmacy. She has also published more than 15 research papers and abstracts and taken on the 6 research projects. Ms. Lee is passionate about advancing the critical care pharmacy through a research and currently pursuing PhD also. She is a board certified critical care pharmacist and serves on the Critical Care Pharmacy Committee of the Taiwan Society of Health System Pharmacists. In her free time, Ms. Lee enjoys exploring the beauty of Taiwan on her road bike. Probably that video was click, right? She finds cycling a great way to unwind and recharge after the challenges of her work. Ms. Lee has been felicitated with many awards like Pharmacy Award from Department of Health, Taipei City Government, Outstanding Publication Award for article in the Journal of American Academy of Dermatology, and also Ms. Lee is registered and active member of Taiwan Evidence-Based Medicine Association, Taiwan Stroke Society, Taiwan Society of Health System and Pharmacists. Today, she is going to talk on the very important topic, that is her topic related to that of the clinical trials and her experience in the hospital that she is going to share from dispensing to discovery, Asian pharmacists empowering the patient care through evidence-based research. With this brief introduction, I take an opportunity and request Ms. Lee to be on the podium for sharing her expertise on that of the talk. Thank you, madam. Yeah, welcome.
Backward, forward. Backward, forward. Okay.
I don't think it's working. No. Can you help? So, I'm trying to check for that. Yeah. Can you try that first? All right. All right, are you preparing? Namaste, sabhi ko. And thank you for having me here. I'm Yahan, or you can call me Alice Lee. And I prepare a few sentences from Dr. Suji suggest, and to forgive me, I have to read it on my phone. Okay. All right, so Muhayana aka ab sabhi si mika bapun kushing ho lali hai. Balaka sawaka kana mile liye ek bahuhi saman kibat ha. So thank you for coming here again. All right, here we go. So I'm, as introduced, I'm from Taiwan. I am specialized in critical care, working in the hospital pharmacy. Today, our topic is going about from dispensing to discovery, agent pharmacists empowering patient care through evidence-based research. I have nothing to disclose in these sections. Here's the outline today. I'll try to finish it within an hour. First, an overview of pharmacy service at my hospital, to introduction to the core elements of critical care pharmacy, and to briefing scope and approaches for conducting clinical research projects, and sharing some of my experience from clinical research initiatives. Last, to review training modules for building research competency while we are in pharmacy education program. So who am I working for? First, you have to know I'm from Taiwan, but where is Taiwan is? Here is the India. Oops. And that's Taiwan is a very small island in the East Asia. So I work in Taipei City, which is Taiwan's capital. It's called the Wanfang Hospital. It's the first publicity hospital managed by the government, but worked and owned by a private, which is a medical university called Taipei Medical University. So I have several experience in pharmacies to serve in the critical care and neurologies and drug information. And also lectures in the campus for the pharmacy students for pharmacotherapy, pharmacokinetics, and literature eval. Oops. Something, okay, cool. And speaking of Wanfang is one of the medical centers in Taipei. So we although Taiwan is a very small island, we still have a lot of patients admitted to medical center every day. Our hospital capacity had up to 750 beds with about 40 is ICU beds. And as for the organizational chart for our pharmacy department, as you can see here, we have the main 5 groups from outpatient pharmacy inpatients to the inventory and clinical pharmacy group, and lastly, education and research. Each of the groups has their adjunct service, including the Chinese medicine, the herbal is prescription Taiwan, operation room pharmacy, and clinical research part, and also IV room for chemotherapy compounding. And then we have the M-Care. This is a very traditional pharmacy workforce in Taiwan. Just like we put a lot in terms of the manpower loading, we put pharmacists mainly in outpatients and inpatient pharmacy, and also emerging department as well. Why is that? Because the most important role for pharmacists in a hospital is to prevent any possible medication error. So by doing that, once an order is established by the physician and finished transcribing, pharmacists went to dispensing and compounding on our own for preparation. Then we deliver the medications to either outpatients or giving to the nurse to administrations to our inpatients. And then we follow audit and monitoring any side effects. And it's important because you know about the choose theory. So pharmacy have to do verification of order, medication reconciliations, while patient transitions, and also being responsible for the discharge counseling. But although it's very traditional, it's essential, but we once had a very serious problem. That is, we are almost invisible in the hospital. And what is that? The patients from the outpatient clinic is wondering, well, about pharmacy, my impression is that who are the ones to give me the medication bag, prescription, and tell me to follow instructions, whatever the doctor says. And then for the inpatient, physicians are feeling pharmacy are those the ones who were calling me all day, but I couldn't see any of them to join my rounding. And we are all sitting because of a traditional working model. Pharmacy, we have to do all the dispensing work on our own, so that kept us very busy. So we have to schedule very small pieces of time sitting in front of the computers, looking into the order entry. So we have no time doing the rounding at a time. So that makes pharmacy almost invisible to a physician. But how can you provide a better role if you keep being invisible to the important health professional? So one challenge issue is, I just put it out there, how can we better support and develop a better pharmacy workforce? Maybe the AI, maybe the automatic cabinet to free pharmacists from the floor. So I provide you a script written what is the ideally look like a medical multidisciplinary team from the American College of Physicians. Like here we go, pharmacist is there, is named as a clinical pharmacist. So that is our ideal goal to achieve and to make pharmacists visible in Taiwan, as I said. So what is the role of a clinical pharmacist different from just regular or staff pharmacist? So here is one opinion from ACCP, American College of Clinical Pharmacists, that says in order for the pharmacist to provide comprehensive medication management, pharmacist has to do including to keeping safe, to keeping appropriateness of medication therapy, also the effectiveness and the safety is the most important thing. And one addition to that is the pharmacist has to be accessible to your patients. So that is the scope of the MUE. I think Dr. Carpenter is going to talk about in the afternoon. So long-term and short speaking, in very long while, we are now visible. So in Taiwan, in our hospital, we had extended our clinical pharmacy service to 8 specialty groups as well so far. Starting from the MCare, and now we have pharmacists specialized in transplants, infectious disease is important, and oncology, critical care, like the team I'm in, internal medicine, and also nephrology. So to let your patient and let the team be familiar with the pharmacist's existence is important. So the scope, I would like to give you more examples about when we first developed the working flow for a critical care pharmacist. That the pharmacotherapy ACCP, which once submitted our document to define the fundamental, desirable, and optimal pharmacy service. So in terms of the critical care field, what does that mean? So I highlighted the most related one to the direct patient care in the red color. For the fundamental is to keep your patients safe from all the prescription, all the medications they went through. So first of all, to be as an ICU pharmacist, you need to be very dedicated to the ICU care. And plus, you have to provide the latest drug information, therapy-related education, the continuing education to your ICU team members, maybe to nurse practitioner, to the physicians, to the residents of the physicians as well. It's important. That's the fundamental. A more desirable model, more advanced way, is to keep your desirable clinical functioning. What does it mean? First of all, you have to be released from your floor, from your chair. Don't just not sitting there for the whole day long. You need to attend the rounds regularly with the member, and so they know they can call you whenever they need. And also, you have to provide a lot of education program, training pharmacy students, residents, fellows, and also through their very experiential critical care rotation to come out with a good syllabus content. And first important showed up here is started to mention the importance of having research, to participate in research and public reports. And last but not least, the optimal, more integrated, dedicated version for the ICU care in terms of requiring of teaching the ACLS, Advanced Life Saving, which I teach at school, and also to evaluate, come up with a guideline and protocol first, and then evaluate their impact to your colleagues. And then in terms of the research, you have to report research results either posted in a conference or published on the journals. That is much more encouraged, which is I often do with my colleagues and my students to do it together. That doesn't mean, not just only me. But importantly, in order to come out with so many different pieces, but you don't want to be too much burn out too early, right? You have to run a very sustainable clinical service. So here's an example of my own weekly time allocation. I spend about 60% load or working time with the clinical to deal with my patients' daily progress. And then I spend another 25 quadrant to doing some administrative work in a hospital. And also I spend last 50% doing research, doing teachings for the institute and for the pharmacy school. All right, so speaking of the clinical research, why is that so important? You have seen it's kind of recommended in the guidelines review articles. So how to initiate a clinical research from ground zero? I just listed several of the necessary steps for you. First is the topic figuring. You need to went through a lot of brainstorming from your daily practice. And then do very detailed, thorough literature review. You don't want your topics to be too novelty or too out of standard. And then you have to go through very thorough and strict study design in terms of methodology, resourcing. I believe many of you have been studying for this one. And then to have a better results interpretations to your team. What does that mean to our hospital? What is the impact it may be? And then to provide a feedback and application of your projects to the member. So most of those students, when it comes to the first practicing in the hospital, they find it most difficulty at the first steps. They got stuck. In terms of the topic finding, I have no idea in my mind. But actually, there are many, many possibilities. So I will just introduce you to run through one by one. You can think of any related topic to solve problems or challenging, conduct more investigational level research, report a unique experience, and also address some controversy, and describe something new or unusual. That'd be good. Document the current practice in review article and review a general topic like this, and even the expert opinions can be considered as publications. But when it comes to more clinical circumstances here, I provide you is to find some ideas, targets for medication use evaluations. So can be looking forward for Dr. Carpenter's talk in the afternoon. And then to address some discrepancy between literature recommendation and real-world practice. Because there are a lot, believe me, regardless of what guidelines say, the real world is real world, it's different. And then time-sensitive issue, any special things, any groundbreaking events is the one developed exploring. And then knowledge gap exists in the literature. Has there been any topics? It's not have reached consensus yet. That's the thing you can try to explore. And then to evaluate some intervention or some programs you made in the hospital to try to evaluate the pre and post difference after the intervention. See, so the tips is the greater dedication to your daily clinical work increase the likelihood of discovering very high value or unresolved clinical issues. So it's not that difficult. And then I recommend in terms of the methodology part, now the important things I always look for is to design a application-centered strategy for maximizing the clinical impact. So this is a 5S evidence-based model. I use that for this term. So we should always think from the very last, like why do I need to explore this project? Once I finish this project, how can I better use to my working? How is that better helping me or to my team? So think of the application at first is important. And here are some steps that you could think of is one, to come up with original studies, including whether interventional or observational. Come out with the synthesis, like systemic reviews and meta-analysis are good ones to try it on. Synapse, and to write some evidence-based journal abstract of studies or some invited comments is all good for practicing. And then in terms of the summaries level, it is to come up with a very evidence-based clinical practice guideline in your own hospital is important. And then last but not least is the systems, which means the more computerized systems here, like the hospital systems, like physician entry, the CPOE. So to come up with some intervention that can be written by the engineers to your systems to work, we call it computerized decision support system. So designing your project with the end goal in mind, so how do I better enhance clinical application? That is always the target. All right, and important thing as well, you don't want to rush out or feeling so alone doing such a huge task without able to finish it. So resourcing, team up, and make a sound plan. So what are the resourcing I may have? Do you have your own electronic health records from your hospital system? Do you need to do a clinical trial data to written in the IRB protocols, get approved, and then trying to recruit patients? Do you like to try published literature or to gather information from the literature for meta-analysis? That's something to think about. And then last, the qualitative survey to distribute questionnaire or have the focus group with the patients is also helpful. In terms of the team collaboration, to consult with professions or statistical experts, don't want to be the one who always know everything, because we do not know everything. And then to work with clinical pharmacists, that's our duty, to define some very important core elements, what is the definitions of my populations, inclusion criteria, exclusion criteria, etc., and to allocate personnel in your team for better data collection and keep things moving. As I bet if you have been to some research projects with your professors, this might be some solid for you to make a very solid progress weekly. All right, so I will provide you 3 of my previous experience for the clinical research projects, and in terms of different 5S model for application. So first, for the know-how is to one application I'm showing you, knowledge gaps exist in the literature. And you know, I am a neuro guy. I'm crazy for neuro before I enter critical care. So this is a topic I came with the AD, emergency department physician, about acute ischemic stroke. We know that once the patient got stroke, it's important time is spent to save him within the first 3, now extended to 4.5 or 12 or a day long. And with 2 rescue strategy. One is to give the IV alteplus, the thrombolytic, and the other is to do the procedure to do the mechanical thrombectomy. And during the time there is only TPA for the IV thrombolysis, it is recommended to dosing patient a very standard dosage, which is total dose of 0.9 milligram per kilogram versus the lower dose, which is whatever lower than that dose. But there are some regional issues in the Asian specifically, is the ethnicity that the Asians may probably, the lower dose can work out well in Asian patients without increasing the bleeding risk and have a similar prevention strategy. But What haven't been resolved is, we know when patient went through the operation way, doing the medical thrombectomy, because of the time window, they can still be benefit from giving a bridging dose of the alteplase. So in that circumstances, does the TPA still require to be dosing as a standard, or the lower dose can work in that situation? So that is our scope to try to figure out evidence that whether lower dose TPA can be effectively as a bridging therapy to MT in our stroke patients. So I work with several teams as here. So we went to the meta-analysis, which I highly recommend you to as a first first topic to work on with your team, because that's easy. All right, so we gathered public original studies of up to 5 observational studies, and it was published last year. It's very short limited, but we can see for the primary outcome, the lower doses TPA versus standard dose in the bridging has actually have no significant difference in terms of 90-day patient functional independence. In terms of important safety outcome, which is a symptomatic intracranial hemorrhage, that patients with a lower dose tend to have a better risk, lower risk without significance. So no difference were noted between agent or non-agents for the subgroup. So application for this project, we published, and we have the rich consensus with our emergency department with a neuro team of, in special circumstances like have the higher bleeding risk patient, the elder patients, to give the lower dose of TPA for bridging purpose is acceptable. And so let's see the one. And the second example I'm showing you is about the pharmacokinetic. I'm not sure if any of you is a pharmacokinetic nerd, but so this is another one related to neuro, is a valproic acid, which is an anti-seizure, anti-epileptic medication. So the neat part about the valproic acid is a very high protein binding drug, up to 80 to 90% of the valproic acid is attached to the protein, to the albumin. So the only effective part of valproic acid are the ones who are unattached. We call it unbound or free concentration. So when you do the medications concentrations for your patient, the blood monitors for the concentrations will reveal a very interesting way, which is the valproic acid will have shows the, I'm sure it's not working. All right, it shows a very saturable protein binding. So look at the left-hand side chart. When the daily valproic acid goes increase, that the free concentration, which is unbound to those ones unbound to the protein, has to show a very linear change in terms of the concentration and dose relationship. All right, so in terms of the total foreign concentration are the ones unbound to a protein and also those ones bounding to the protein. It's going to have a very long linear change. So is that important at all? Well, there's a discrepancy that happens from our practice. So before this project I conduct, there was we couldn't get tests for the free-form valproic acid in our hospital because of the cost issue. So we so wonder, is it essential and needed in our hospital? So I come up with the idea and gather the critical neurosurgeons and one neurology guy who are very friendly and supportive. So we conduct an IRB foreign protocol. So for the prospective trial, to test the patient, we got patients' blood drawn to test them their total foreign and free foreign valproic acid at the same time, whoever dosing at a steady state. And we applied a grant as well to cover the laboratory fee. So the lab guys will be willing to do this for us. All right, so we would like to address these questions. First, to check the concordance between the total foreign and the free foreign in our patient. To find the potential predicting factor, for example, whether the albumin lower level will influence this is called hypoalbuminemia, to evaluate the distributions between the concordance and the daily dose. So after 6 months of data collecting, this is an interim analysis. Most of patients, I know it's very small sample size, we collect from our ICU patients. And the interesting thing is the neurocritical ill patient tends to show high rates of the valproic acid free and total concentration discrepancy. So in the table here, you can see if you listed the concentration into 3 categories from the therapeutic to reach the goal. Lower than that, we call subtherapeutic, and higher is the supratherapeutic. And you can see the meaning of concordant here means to getting a test and categorize from the free-form valedictory AC can generate the same result as the total form. So the concordant ratio in our group is only less than like 70%. And for this concordant, which is outer brick here, it's up to 30%. Does anyone of you think the 30% ratio is high, considered high here? Or consider, okay, that's not too high, acceptable. All right, in terms of the neurocritical care, we only gathered 22 patients and have 7 of these. So it's actually a pretty high number and scary. So we're trying to develop, so we divided a patient who are falling to the concordant group versus discordant to see their difference in the serum albumin level and the free fractions calculated. And can see patient with a discordant, which is in the red colored bar, with discordant drug concentration, they often tend to exhibit a higher unbound fraction, which makes sense, right? And lower serum albumin levels compared to the concordant patients. So because of the limited sample size, this data has not generated to run any significant test, but we can know it's a pretty obvious trend right there. So how do we implicate this as an example to our clinical working? Let's assume when your patient is at a low albumin level, that is very thin, very cachexia, is a dialysis patient with an ESRD. Once he or she is admitted with the valedictory acid dose, and when the dose comes out, reaching the new steady state, the concentration from the total free form will comes to reach actually very steady fractions compared to the first one start dosing. So it will tends to be a flat form, but for the total concentration form, because once you increase the dose, the clearance will increase as well. So the total form is going to tend to decrease. So if a physician only see the concentration level from total form and decided this level is subtherapeutic, I need to dosage higher for my patient to get the seizure control, that will bank into a very safety concern issue because valedictory AC has known for liver toxicity, hyperammonia, other very important serious side effects. So this project is a theoretic proof that in patients with hypoalbuminemia, any dosing adjustment merely relies on total form is at risk of putting your patient become overestimated dose. So far, this research we went had finally led ahead in the hospital laboratory to officially confirm and adopt to have free-form pre-S testing. So we'll have that running in the future soon, hopefully. All right. The last project I'm showing you today is about one of our guests just mentioned, the pandemic. So during the pandemic time, I'm not sure what is it going on for India at the time, but for Taiwan, we went to a kind of delay trend from the international trend. So this is the trend when the time, remember, pandemic starts at 2020. So the rate is the world cases accumulated, but Taiwan, because of its islands and our CDC come up with some strategy to keeping on our gate. So we hold the trend without an outbreak happening until late 2020 May. But at the time, when it started exploring and exploding in Taiwan, we are into a very panic situation because we lost the previous 2 years of getting familiar with dealing patients' situations. So everything just went chaos in a very short time. So here that was a crisis response to our research for I remember that's the Omicron wave. So what do we as pharmacists do at the time? So yeah, that's a background. So first for your ARNT medications, so our Taiwan FDA so likely issue the emergency use authorization for 2 oral antivirus. The Paxlovid, in brand name, is a compound is a nirmatrelvir, ritonavir, and also the other drug, molnupiravir, in January 2020. Which indicated for treatment for patients with moderate to mild to moderate COVID-19. But without enough time of getting familiar with it, an Omicron outbreak all of a sudden in May in Taiwan. So to counter that, our government implemented a very strict home quarantine policy, shifting away the previous strategy. Previously, the patient just have if that has diagnosed of the COVID, because the patient number was so low, everyone has mandatory to be hospitalized. But after the surge outbreak, the policy changed that everyone need to go home and be quarantined and do not come out. So the stage planning in response to Taiwan CDC's policy, that is first the emergency department was coded, designed as the focal point for the rapid antigen screening and large-scale distribution of oral antivirus to patients who are about to just got diagnosed and leaving to home, which led to a very significant triage overload. So it was a chaos everywhere in the, I'm not sure what's that in the state at the time, but in India. All right, so some puzzle comes out. First is dynamic change policy actually leaves the provider very confused. They were firstly very frustrated dealing with the complexity of oral antiviral selections. So here I just posted up some of the pros and cons of choosing this or that. So for Paxlovid, at the very first time, it kept changing the usage as well. So at the very first time Paxlovid be granted at the EUA, it needs to require renal function adjustment, and it's contraindicated for those getting dialysis. But for the molnupiravir, there's no such requirement. For Paxlovid has very significant and a lot of drug interactions. So if you don't know your patients like the refill or the chronic medications, it will be a little danger just putting them on the Paxlovid, because the concentration will go crazy and high. Patients will suffer from a lot of serious side effects. And molnupiravir, there's none of this issue. And last is for the tube feeding, the nasogastric tube feeding. Paxlovid was firstly saying, no, you cannot doing that, only molnupiravir is able. But now Paxlovid is open as well. So see, just the usage change by the time. All right, so whether to choose this or not. And the other thing is the patient are so grounded, they're drowning, they're just quarantined at home and cannot reach enough information. So there is a significant lack of head-to-head comparison safety data between these two medications in real world. So there is a main need for the patient. They are lack of access to adequate patient educations, because they are sending home right away after they got diagnosed with a prescription without not really know what to take. So what do? We come out of a step series of response for the crisis. We assembled a hybrid team. So it was me, another very nice, smart infectious disease pharmacist in the picture there. Two pharmacists with one ID doctor. We went into the ER to establish a daily COVID round to visit our COVID patients at ER. And we, after we come up with decisions, we try to educate the ED physicians to do what we can do to know how to prescribe medications and select. And then we come out to go to the backward to writing, build up protocol and guideline. And then for the patient, we established a telepharmacy service implement. So we come out with the paper on the right-hand side to use the QR code for the patient, asking them scan from their phone. It's like the WhatsApp, we use as a line. Also, patient can get unhooked with us. So whatever the question they have, we can untrack on them. So it's important to getting your transition care done. So this is example process of that digital platform we adopt using line here. We first pharmacy, again, we do a dispensing. So we look at eligibility from the National Health Insurance Cloud, which we can access their outpatient medication fill list. to run if there is any significant interactions. And then we have a patient prescribed oral antivirus. When order verifications, we ask them to using QR code together with our line up together. So while at home, we doing the remote monitoring for the safety check, and to open questions for any patient will have for counseling. Education is also provided as well. And then we also do you need to refer to outpatient? Do you run out with any emergency? Do you need to come out to the ED? So we try to rent out several. So this is an example of what we've done. We want the texting to be very structuralized. So we won't just get loose in the wood for forever, keep it there forever, chatting with our patient. We don't want that. So we did 3 levels of asking automatically. From the first 3 days, we do the patient to identify the validations. We do the medication education through the message. We check in their adherence, which is because the first 2-3 days is most vital for taking antivirals to get help, and do the MAREC and to remind the instructions specific regarding the interaction to hold your statin for a few days, for examples. And then this next sections from the day 3 to day 7, we ask them, do you have any symptoms, how's the relief, what the side effect, and also to ask if there's any emergency to need a transfer. And the last part, we do the virtual check for the resuming and transition discussion. So we evaluate the outcome for this one. So this is, again, we collect the data from the EHR, and also is with the remote monitoring texting context. So this is pharmacovigilance surveillance. So we aim to investigate the effectiveness and safety between these 2 antivirus. So here is the data for the safety. You can see the bars in the orange color is Paxlovid that has like almost 3 times higher than the patients taking molnupiravir to experience adverse drug reactions, have very bitter taste, to have stomachs, diarrhea, to feel weakness, kind of thing. And then also a big portion of them actually did forget to resume or to on hold their first structures outpatients medications, which would put them dangerous into have other like adverse reactions as well from the interaction. And some is actually has a contraindication to either one, but the physician at first did not notice that, but prescribing the medications. So we did this remote surveillance. Figure is helpful identifying the DRP, facilitating comprehensive medication use, even during this kind of the chaos transition period. And then we did a second part for the effectiveness evaluation. So we collect the first distributed 312 patients from either getting the Paxlovid or molnupiravir, that we evaluate whether they run out of any emergency situation. So to examine the prevention of these 2 antivirals. So the first outcome is a composition of hospitalizations or mortality. And you can see the Paxlovid group has a lot less risk compared to the molnupiravir for letting patients come up with these situations. So it's way better for the prevention effect. And also its significance for preventing patients from getting hospitalizations as well. And on the right-hand side is the survival analysis. You can see the same significance trend of Paxlovid have better survivals in terms of the composite outcome. So the application was that we reinforce education to our clinicians again, not only in the ED, but also the whole inpatient, outpatient group, because they are now have the chance to describe these medications about the difference between these 2 oral antivirals. So clinical efficacy should outweigh the convenience, regardless of this drug need to be dosing, need to be held. So for example, but Paxlovid is way better than molnupiravir if your patient is eligible to doing that. So given that. All right, so the last part of my talk is, in order to come out with all this research, I'm very fortunate because I have the graduate experience from my graduate program. But not every pharmacist get a chance to explore this part while they are in college. So we, in Taiwan, the same, we had a traditional 4-year bachelor program track. That is come up the main subjects from the curriculum for our 4-year B Pharm. But in 2015, which is 10 years before, we started in my TMU college system. We come out with another 2-year more, so it's 6 years bachelor programs. We call it PharmD, but the government still recognizes it as a bachelor, but it's a 6-year training. So it contains the subjects of the same for the B Pharm curriculum, and plus a lot of beneath is more experiential, having pharmacotherapy modules, and also built around to have have students competent in doing clinical research for the research methodology, clinical trials, and the students get to practice a lot during their advanced pharmacy practice experience. We call it AP year. So they spend their 6 years, a whole year in the hospital doing the rotation with us. And so in their the P6 year, they need to do at least one clinical research project with their preceptors. All right. So after the graduations, when you start working in a hospital, in our systems of TMU, we also provide additional continued clinical training for becoming a more equipped clinical pharmacist. We do a general one-year residency training, and ideally, we would like to schedule for a 2nd year specialized residency training. Depends on whether you have enough preceptor doing that. And then, so in terms of the pharmacy degree for the graduations, that whenever if you're coming from the 4 or 5 years, 6 years before, or with postgraduate programs experience, you can have all chance to have more experience after you start working. And after you acquired, you get a BPS certificate in the United States, you can also apply to becoming a specialized pharmacist. Okay. So here just some examples. I'm not going through the details, showing we had very wonderful students that I precepted with, and we ran this collaborative research project together and made it to the posters, even went to the ASHP 3 years ago. So whether it's a neuro topic, in the ICU topic, so the students is able to make and have a very experiential things to have interest during their internship in the hospital. So the Asian pharmacists are evolving beyond traditional dispensing roles, that by becoming integrated members of your multidisciplinary team, actively contribute to clinical decision making. And we are able to get a chances of making clinical impact with very solid evidence-based approach. So it's important that you know the EBM very well during your in the college time, and to seize any chance, just like the pandemic we went through for the COVID-19, the pharmacist has demonstrated their values by managing the very complex medication protocols and situations with physicians together. And also to build a research capacity from college in time is very important for you now. So through student rotations and cross-disciplinary collaboration, the pharmacy education is foster strong research skills and engagement. With that, it's all of us here now. So thank you for participation. Okay, thank you. Are you going to have a Q&A? Oh, is there something?
Thank you, ma'am. We would like to express our sincere gratitude to Miss Alice, ma'am, for sharing her valuable insights with us.
Now we will open the floor for questioning. Please raise your hands and ask if you have any query or question about the session. Please raise your hands and ask if you have query or question about the session.
Yes.
How active a research will be once a paper is published in Taiwan, some research article is published. Because we in India, once a research article is published, that research will go in term, only we will work for publication.
So the question is, how long it would take after the research projects have been done to the publications? I think that highly related to the efficiency of your of your research team. So I had experience to have a short communication like essays being accepted by JCI journals within a month. With very in time submitted, but sometimes it can run a very long way to a year and a half, for example, to get it published. So for the meta-analysis article I demonstrated, it actually took us up to a year from submitted to being accepted at final. So as I mentioned in the slides, you need to really, you cannot run by yourself of all doing these tasks because it's so long lasting. Yeah, so I have 2 minutes. Thank you.
Yes, sir.
So nice presentation, Lee. Congratulations.
Thank you.
2 questions in my mind. One is how you get the clinical gaps, whether it is day-to-day practices or you have some confined strategy for that. And second question is, I'm really impressed the way you have established clinical practices in your place, at your place. Do you have any strategy, or are your country or your scientists are working how you will cope up with superbugs? Because if you are identifying the things day to day, the clinical gaps, do you have some plannings? Because it is not, it is going to come very soon across globe. Yeah. So are your countries working on that?
I don't have any experience working in a pharmaceutical.
Sorry?
The second question is?
There is a threat of superbugs across globe, antibiotic resistance. So in your clinical practices, are you planning something or you have some trials on that?
Have some plans on the...
Your group is working on that?
I think we do. We do have the patients, committees working for that part. And so it's very important that comes to the question number 1, that how can we collect the data from our daily practice. And it's actually, it is prohibit for the HIPAA issue to the ethic issue. You cannot just simply collect the patient data. So you need to, any research project that is involved into the published base is required to submit through the IRB protocol. But one exception is that if the purpose of doing so is not to getting published, but to getting more like a quality improvement in evaluations, just like the MUE, medication use evaluation, it is acceptable to not have the IRB run first and to collect. Yeah. Thank you.
One more question.
Okay.
How your country deal with expired drugs as far as clinical practices are concerned? It's a very, big thing in our country that still we are, unable to sensitize the persons how to deal with expired drugs. So what are your strategies in your country? How you are dealing with expired drugs? In a common man, if they are handling with the drugs, physicians has prescribed the drugs and the patient has taken. But there are few cases where the OTC drugs are there, they're going to expire sometime. So how your country deal with the expired drugs? Do you have any strategic planning or at your country especially? I would like to really eager to know that.
Yeah, I do not have the questions for an answer to that right now, but I will think about that and talk to you and discuss with you later if I can tell more. Yeah, thank you. Good questions.
Ladies and gentlemen.
Okay. Sure.
A few questions I will ask on the behalf of students because there are students and it's a more focused topic.
Do you
So
need
I
mic?
think I will take the mic.
Okay.
It will be more interesting that if on the behalf of the students, if I can put the questions. Hello? Am I audible? I will go to podium. No issue. On the behalf of student, I will ask few questions because you have discussed some curriculum related to that of the PharmD also. We have the BPharm program in India, then MPharm, and then the PharmD has already been there in the, you may say that of the few colleges, right? Now, the educational system over there in the Taiwan, and how is that? Can you give some sort of the highlights related to it because you have completed your BPharm as well as the masters also?
Yes.
So just give some highlights related to it.
Mm-hmm.
So 5 minutes I will take, not more than that.
Yeah, very good questions. So the questions is about from the beginning. So what is the complexity like in Taiwan in terms of the many different diverse pharmacy programs? So Taiwan is actually, it's pretty much, we were told that we're, the clinical pharmacy development is kind of in the 20 years behind the practice in the United States. So we were at a time when it comes to the first 2000 years to 2010, that was a time that many pharmacy school, many college of pharmacies, we had the bachelor programs the most in more than the seven college in Taiwan. So they come out from a 4-year program to extend it to a 6-year program gradually and in a sense 10 decades. And to a point of now, there is only almost all the pharmacy college in Taiwan has been integrated to 6 years before. And only for the TMU season I work with have a combination of 4 and 6. Yeah.
One more question, that is how the data handling, whether there are some specific type of the systems at your country for handling this type of the data. The case studies that you have presented, it is from your hospital one. While handling the data, what type of the care one has to take?
Okay, yeah, good questions. So where can the data come from? So for the research I shared is from our own hospital with patient information, but in Taiwan, because we had very unique national insurance things, so almost more than 99% of the Taiwan citizens is covered in the national insurance. So, which means you can acquire and get a national level of patient information from these, we call it NHIRD, National Health Insurance Research Database, to do a more nationwide studies, retrospectively, by the way. Yeah.
Thank you. Thank you very much, madam. And it was a wonderful presentation. And I think the audience will get the more idea related to that of the topic that you have selected. And probably it will be the beneficial to them in their research work also. Thank you very much.
Thank you, Chair. Thank you.
Thank you, ma'am. Thank you, sir. Ladies and gentlemen, we are now poised to embark on a discussion that promises to be both insightful and impactful. Before we delve into the heart of matter, it is essential to understand the framework and objective of this session.
May we have a privilege of inviting our session chair, Dr. Atulshri Khetkar sir, to share about their words about session.
It was a wonderful session that you have started from that of the dispensing to the discovery one, and truly the topic has reached to that level, that is how the pharmacist can contribute in the area of that of the discoveries one. Initially you may say that of the role was restricted only to that of the dispensing of that of the drugs, Many case studies also you have shared in your the presentation one, that really remarkable one, and definitely the researchers will get an idea that is how to present the data systematically, how to evaluate the data, and then how to prepare the protocols also for that of your the studies one. That idea will have related to it. In your presentations, you have started with that of the optimal pharmacy services one. That is also the points that you have mentioned, certain points related to it. Evaluation of that of the data also mentioned. So these are all the aspects related to the clinical trials and clinical services one that you have mentioned will be useful to the country like India also, because they are going with these type of the programs right now, and there will be the big scope for that of the clinical pharmacy in India. And the way the presentation actually will be the helping for that of the students and that of the faculties as well as the participants one to study the things in that of the clinical area one. So overall the presentation was nice. I can say that the big clap for you. Right. Thank you to the organizers also. Thank you very much.
Thank you so much, sir, for your valuable words on this session. Your words has added great understanding to us. We appreciate your time and expertise.
We are now going to take a moment to reflect on the significant memento that holds a deep meaning. This object serves as a beautiful reminder. Now, we would like to present memento to our esteemed session chair, Dr. Atul Khetkar sir.
And I request Dr. Prabhat Kumar Das sir for presenting the memento to session chair Dr. Atul Khetkar sir. Thank you, Dr. Prabhat Kumar Das sir, for presenting the memento to our session chair. Presenting a certificate of appreciation is more than just a formality. It is a way to express our gratitude for the knowledge and insights shared by our keynote speaker, Ms. Alice ma'am.
At this time, we would like to acknowledge the valuable contribution of our keynote speaker. Please join us as we request Session Chair Dr. Atul Khetkar sir to present a certificate of appreciation to keynote speaker Ms. Alice ma'am. Please join us in a thunderous appreciation.
As we move forward with the program, we kindly request our esteemed speaker and session chair to occupy their seats of the dais.
Once again, we extend our sincere thanks to our session chair, Dr. Atul Khetkar sir, and speaker Ms. Alice ma'am for their excellent moderation and guidance for the informative presentation.
Attention participants, the poster presentation session is open as lunch is announced. Presenters, kindly ensure you are at your respective posture as soon as you have your lunch. Be ready with your posture for presentation and kindly check that it is properly arranged at a display site.
Now it is time to take a lunch break. Enjoy a wonderful lunch we are about to offer. Lunch will be served from 45 minutes from current time, and we kindly request you to be back on time as we will resume next session promptly immediately after the lunch time. Enjoy your meal, and we look forward to welcoming you back in 45 minutes from now. Good afternoon, everyone.
A very great afternoon, everyone. I really hope you enjoyed your lunch. Moving with the schedule,
Let us embark on this enlightening journey of knowledge. Let us take a moment to acknowledge the distinguished speaker who will share her expertise with us.
to introduce our eminent speaker, Dr. Bethany Carpenter, ma'am, let's see a short video. Please kindly direct your attention to the screen.
Thank you for playing a video. Thank you for playing a video. To proceed with the program, it is my privilege to invite our respected session chair, Dr. Nilesh Malviya sir, and our respected speaker, Dr. Bethany Carpenter ma'am, to kindly join us on the dais.
Sir and ma'am, please kindly come to the dais. Ladies and gentlemen, we are now at a pivotal moment in our program as we prepare to welcome our speaker who has made significant contribution to the pharmacy field.
To provide the proper context, may we have the privilege of inviting the session chair, Dr. Nilesh Malviya sir. Please join us in extending a warm welcome to Dr. Bethany Carpenter ma'am. Thank you so much, sir, for a warm welcome.
To formally welcome our session chair, a great academician and researcher, Dr. Nilesh Malviya sir, Principal at Smriti College of Pharmaceutical Education. We request Mr. Naren Singh Bhadore sir to extend a floral welcome to our session chair.
Everyone, please give a huge round of applause. Thank you so much, sir. Let's move on with the program. It is a privilege to introduce our respected session chair, Dr. Nilesh Malviya, sir.
Dr. Nilesh Malviya sir, Professor and Principal at Smriti College of Pharmaceutical Education, Indore, Madhya Pradesh, and recognized as a ZED consultant under the MSME Sustainable Certification Scheme. Sir has taken up research projects from DST, AICTE, and MPCST.
Sir has many collections of scientific accomplishments. To name a few of them is the APTI Young Pharmacy Teacher Award, IPGA Best Academician Award, Young Scientist Award, Eminent Professor and Principal Award by IPA MP State Branch. The list is endless for his achievements. Sir has been granted 4 patents and published 34 patents, granted 14 patent designs on laboratory equipment and has 146 publications. He has also authored 12 books and 13 book chapters.
Sir has guided 6 PhD candidates for the award of doctorate, 62 postgraduate research projects to date. He is an honorary life member of VIBHA, IPA, APTI, Indian Society of Pharmacognosy, IPGA, and Society of Ethnopharmacology. Now, as we proceed, it is time to hear from our esteemed Session Chair Dr. Nilesh Malviya sir, who will share his thoughts.
With his vast experience and deep understanding of pharmacy field, Dr. Nilesh Malviya sir is the perfect person to highlight the contribution and expertise of our honored speaker. May we request the session chair to introduce and invite our speaker for the session.
Hello. Good afternoon, everyone. I, Dr. Nilesh Malviya from Smriti College of Pharmaceutical Education, Indore. Welcome you all the delegates, all the dignitaries, all the student participants, all the faculty members in this GRYPICON 2nd International Conference 2025. I'm very delighted to welcome you all, distinguished delegates, eminent guests, organizers and participants in MPCST, ICMR and BRN's sponsored 2nd International Conference. And the title of conference is Clinical Trial Addressing Practices, Challenges and Global Innovation, organizing by esteemed institute, GRY Institute of Pharmacy. I'm extremely pleased to thank Dr. Sujit Pillai sir, Principal, GRY Institute of Pharmacy, and organizing team for inviting me to chair this session. Pillai sir, my mentor as well as my beloved friend, is an iconic figure in the field of pharmacy, in pharmacy academic profession. It is his visionary initiatives and innovative practices that has enabled him to reach hero height in the field of pharmacy. ये बात बताने की नहीं है, but ये मैं फिर भी बताना चाहूँगा कि मुझे लगता है कि in a week, in 7 days, शायद ही कोई ऐसा दिन होता होगा जिस दिन सर से मैं बात नहीं करता हूँ. कई बार मेरी वाइफ मुझसे बोलती है कि मैं जब कॉल हिस्ट्री चेक करती हूँ तो मुझसे ज़्यादा आप बात पिल्लई सर से करते हैं. हाँ, this is the reality. Why? Because when I have any type of query related to college activity, related to professional activity, whenever I need some guidance, he's the right and the first person to whom I always talk and discuss what kind of issue I have, and any kind of suggestion if I require, he is the only man and he is the true mentor always. मैं चेयरमैन सर भी यहाँ बैठे हैं, बताना चाहूँगा कि at what extent I associated with GRY Institute of Pharmacy. In 2012, I participated first in DST sponsored conference, and I got award at the time of oral presentation as a student, as a PhD scholar. Then in 2013, I think MPCST sponsored conference sir organized, and I participated in that also. Then in 2022, first international conference, and this is the 2nd international conference. Sir also added me or honored me as a advisory board member of GRY Institute of Pharmacy. So this is my long association and great association with Pillai sir and GRY Institute of Pharmacy. And I am fortunate because, yes sir, if we talk about 5 good quality offering institute in Madhya Pradesh, GRY Institute of Pharmacy definitely reckon in this ranking pattern. Why? Because in Indore and in particularly metro city, institutes are having so many facilities. But if we talk about GRY in Borawa, what kind of infrastructure, what kind of recognition, accreditation you received or you recognize, it's a very commendable job by the principal sir and the team member. So definitely they all deserve a big round of applause. And it's a very kind of motivation for all of us also, all other academicians, that we can do. It's our time to do something extraordinary like GRY Institute of Pharmacy is doing. So coming to today's 2nd technical session, we have with us Dr. Bethany Carpenter. On the behalf of organizing team and on the behalf of Team India, I welcome you, ma'am, for this international conference. It gives me profound pleasure to introduce Dr. Bethany Carpenter. Dr. Bethany Carpenter is a clinical pharmacy supervisor at Marine Health Medical Center in Green Bay, California, USA. Dr. Carpenter completed her doctorate in pharmacy at St. Louis College of Pharmacy and completed 2 American Society of Health System Pharmacists accredited postgraduate residency program. First year at St. Louis College of Pharmacy and Mercy Hospital, and second year specialized in infectious disease at University of Minnesota Medical Center. Dr. Carpenter became a pharmacist to study pandemics, manage antimicrobial stewardship program, and improve population health. She discovered a passion for teaching early in her career and began working at a college of pharmacy, raising student awareness about postgraduate residency opportunities. During the pandemic, she transitioned to full-time clinical practice as an antimicrobial stewardship program coordinator. In this role, she became a leading hospital educator, developing institutional guidelines for COVID-19 pharmacotherapy and conducting clinical research. Her recent career endeavors have led her to clinical management, where she now oversees 25 pharmacists, manages the medication formulary and clinical research, and coordinates several medication programs aimed at improving safety, optimizing pharmaceutical management, and ensuring cost-effective therapy in a community hospital. Dr. Bethany Carpenter has many publication and conferences presentation. Additionally, she has completed 6 major project and research assignments. Today, Madam will speak on practical, not pretty, making the most with medication use evaluations. Madam, all the participants, including me, are very much excited to learn, to listen your insightful talk. And once again, thanks for joining us. And please, now podium is yours.
Do you want me to try to hold it? No, I don't. I can hold it. Yeah, I can hold it. It should be fine. Okay. All right. Well, oh. Down. That? Testing? Okay. Can I get some water? Namaste, Sabiko. Mujhe Yaan Akar Apa Sabi Semika Bahut Kishi Ho Rak Hai Hai. Thank you, everyone. I don't speak many other languages. The best I got was Spanish all the way through high school. Hola, ¿cómo estás? All right, so today I'm actually just going to talk a little bit more about some of the practical elements of research. Dr. Lee actually mentioned quite a bit of it, and she hinted at a big topic that I'll be talking about, and it's actually quite integral of the fact that you're hearing it from someone in Taiwan. And in America, it's actually quite a staple in terms of how we do research on a clinical perspective. So I have a title here that talks about more the practicality. We all think about research and we think that, you look at those research papers and you look at those graphs and you're like, oh my gosh, how could I possibly do that? And actually, just looking from your guys' abstracts, you guys are doing quite a bit of research. And I'm sure you're collaborating with each other. And so I wanted to provide some perspective of how we conduct research and collaborate within an inpatient hospital setting, which is kind of where my specialization and expertise has led me to this day. All right, so how many of you guys are familiar with the United States of America? Good, all right. For those of you who aren't as familiar, we've got 50 states. Many of us do like to travel across the states, but several of us tend to stay in the same place. However, my path is a little different. So as we are kind of discussing, I did want to share a little bit about where I've been in the United States and give you a perspective that medicine is practiced similarly yet differently in every place. But the other piece to it, too, is what you guys are doing here in terms of developing PharmD programs. So my first time of coming in, I came from high school, and I went to college. It was a 0 to 6 program at St. Louis College of Pharmacy. And I also completed a PGY1, so postgraduate year 1 residency program. So what that is it's additional training within an inpatient experience in the hospital that really focuses on clinical pharmacy and pharmacotherapy management. So from there, I actually moved back home. I'm originally from Minnesota. It's a little colder and a little bit more tundra, and that's actually where I decided to specialize in infectious diseases, particularly antimicrobial stewardship. So that focuses on how to actually manage patients and reduce the amount of antimicrobial resistance that's not needed in patients in the hospital. And from there, I moved over to California, where it was bright and sunny. It's a little different in terms of practice. It's a little different in terms of what you see there. These two places, though, are probably my two favorite places in the world. There's a cartoon called Snoopy, or the Peanuts Gang, if you guys ever know about that. So that's kind of some of the notes that you'll see both in Minnesota and just north of the Golden Gate Bridge, and that's actually where I work. So the hospital I work at right now is actually a community hospital. We don't do research. We don't tend to publish a lot, but I have a lot of background in publications in the past, as well as understanding some of the foundations that we learned in pharmacy school that have led me to continue to essentially do research in my hospital, but we don't publish, so we don't get IRB approval. However, a lot of the principles are the same. So what we're going to talk about today is outlining important design aspects to conduct a successful medication use evaluation, identify barriers or challenges to overcome when conducting a medication use evaluation, and describing how principles of MUE translate to successful clinical research or initiatives used to evaluate practice. So Dr. Lee talked a lot about her research, and there's actually several notes that you'll probably notice that track from hers as well as mine. And most of the things that I want to talk about are really principles on how would you actually use the same elements within research, but conduct it in a clinical setting. Okay, so has anyone ever heard of a medication use evaluation before? Okay. How about randomized control trial design? See, a few of you guys have done abstracts. Have you guys been doing RCTs, or is it more retrospective studies? What type of research are we doing here? We don't know? All right. So medication use evaluations is, quite frankly, the exact definition of it. It's a study that you're looking at in terms of medication use in the hospital. So why would I talk about it at a research conference? It is studies and it's research, but it's within the scope of a clinician. So practicing day to day, rounding with physicians, making recommendations on pharmacotherapy for patient care, so those patients that we're seeing on the floors, all of that is single points. However, at the end of the day, when you start making patient-specific recommendations and you're not actually sure, does this actually help our whole population as a whole because it was different than those populations studied, how do we actually know we're doing the right thing? And so that's actually why medication use evaluations have a whole subset of design, a whole perspective of how we actually should be implementing it. And it's the clinician's way of making sure that we're actually taking care of our patients. The neat thing is the methodology is very similar and publishable at the same measure as any other kind of clinical trial. All right, so what do we have in the United States? So we have several regulations that actually say that we should be doing medication use evaluations within our institutions. The Joint Commission is correlated to our Centers of Medicare and Medicaid, which actually will reimburse hospitals. And what they're saying is that our hospitals need to actually audit themselves. We need to be doing research within each hospital and look at how are we actually using medications. Are we using it the way that it was prescribed? Are we using it the way that it's safe to use? And not all the time do we discover that's the case. So in order to actually conduct those studies and show that there is a true correlation with the way that we're practicing and the results that we're seeing, there's a set of guidelines that are outlined. ASHP is one of the most well-known organizations out there. It's American Society of Health System Pharmacists. This is the same organization that's used to accredit residency programs. And so they actually published a set of guidelines saying if you're going to conduct research within a hospital and you don't want to publish, this is actually our criteria on how you'd actually design it. Okay. So how do they define an MUE? It's a systematic and interdisciplinary performance improvement method with an overarching goal to optimize patient outcomes via ongoing evaluation and improvement of medication utilization. Does that sound like a study to you? Maybe? I don't know. All right, so let me translate that. It essentially is a study that's conducted to assess medication use, focusing on safety, efficacy, and adherence to clinical practice guidelines and evidence. So most research, and some of the research that you actually heard from Dr. Lee, it was a question. Does this actually work? Is this actually going to work for any type of patient population, but then putting it in within the setting that she was researching? What a medication use evaluation is saying is we know what the guidelines are. How do we actually make sure that we are using those guidelines in our hospital correctly? And so this is actually research that develops over a process rather than a specific intervention of a medication or act of a medication. So here's a side-by-side of what we typically will do when we're looking at scientific research and we're studying a drug. On the right-hand side, you can see, or sorry, your left-hand side, you can see there's an acronym that's commonly used for developing research. So PICO. First, you want to identify your patient population. Most of the time for investigators, they're going to actually want to pick a subset of population that's as similar to each other as possible, because then you can reduce the confounders, right? So the investigator actually gets to choose their patient population. The second thing it does is establish an intervention. So it's figuring out, do I investigate if this drug is going to impact this population? So let's take that as a similarity to a medication use evaluation. We are studying a process within a population. However, the population tends to be something within a specific institution. So that institution could be a community-based hospital, it could be an academic hospital, and the populations will really vary based on where they're actually getting their care. So that patient population's helping to find the process that's targeted for that improvement. And then you want to organize your team to figure out, okay, who's actually doing that process? So similar to the population, who are the group of individuals that are being impacted by the medication use that we're about to study? So the major deviations that you start to see is when we start to go into our comparisons. So on PICO, we're looking for a specific comparator. So is it a medication comparing against placebo? Is it a medication comparing against another medication? In a medication use evaluation, we start going beyond that. Most of the time with medication use evaluations, we actually don't really know what the process is. And so instead of actually comparing things, we're actually starting to look for confounders. So we have to think about what are all the variations of someone's practice of how we're possibly using the medication to be able to refine the data that we're looking at. And then the last thing is what the O stands for. So Most of the time when you're looking at an intervention, whether it's a medication versus placebo, you're wanting to know what is the actual outcome. And so you have predictive ideas, right, from possibly preliminary studies of phase 1, phase 2. We know this drug reduces blood pressure. We know that there may be some potential safety parameters. And then when you get to phase 4 of your drug trials, you're looking at that at a larger scale. So you already know some of those outcomes that could be measured that show the efficacy of that drug. But when you're going through a medication use evaluation, you're looking at all the variables, what are actually impacting medication use, and then you start to figure out how do you actually refine that use process. And so that's the selection process and how to actually improve it. Okay. So major differences is oftentimes in standard research, you're looking at a specific medication and whether the actual medication worked or if the way that you're using it is working exactly. And then for medication use evaluations, you're often looking at a process. Are we actually using the medication correctly? Okay. So the last piece of differences between our standard research and medication use evaluations is what happens afterwards. As you noticed with Dr. Lee, she actually has publications that came out, right? The literature gets shared amongst everybody. You get a lot of notoriety. You get to go to conferences. You get to do poster presentations. It's really exciting. And then someone finds that piece of literature and says, hey, you know what? I think that this is a really good piece of literature. This is a really good drug. The results actually make sense. Let's put this in the guidelines. It totally makes sense. All right. So you've gotten into a larger perspective of how we manage patient populations, and that's actually how our clinical research will become large-based guidelines. But let's take an MUE as a focus. So when you're looking at medication use, the buck doesn't stop at your recommendations to improve a process. It becomes a cycle, and this is actually a very important piece that the ASHP guidelines outline, is that when you're going through and determining this is a process improvement that needs to happen in the hospital, then you have to come up with recommendations on how it's supposed to be implemented. Then you have to think, okay, how is this actually going to be done? You start to do it, and you go through the whole process again. So a medication use evaluation can lead to another medication use evaluation, which can lead to another medication use evaluation, and you can see how the cycle can perpetuate itself. The reason why they emphasize this, though, is because when you're practicing medicine, it's ever-changing. There's no way that you're just going to stop here and say, this is the therapy I'm going to be recommending to patients for the rest of my life. New drugs are going to come out, new guidances are going to come out, and it's your job to be adaptable as a clinician and actually conduct those studies in the hospital saying, okay, we have this old drug we've been using for a really long time. Okay, we just brought this new drug in. Okay, is there a difference? Should we be switching over to the new drug completely? And that's actually what I do every day, and I'm looking at all of the different medications that we have on our hospital formulary and determining, do we actually need to study this? Are our physicians using this correctly? Okay. So I talked a little bit about the triggers as I started on my rant in the last slide, but there are major steps or pivot points that help us identify, yes, I need to do a study. Now, the reason why we actually have to know what those triggers are is because we don't do research day in, day out. It happens because of a need, and it's usually a lot of time has to get spent outside of working on patient care. I have to help my pharmacists with their goals and aspirations. I have to make sure that adverse events are not happening in the hospital, and I have correction measures with that, right? So when I have a medication that gets brought in, I have to know, when is my pivot point? When am I going to start looking at how my providers are starting to use the medication? Because we have FDA approvals. Yes, the drug works. We're going to add it to the market. But once it gets to the market, who's responsible for making sure those providers are using it for, one, the FDA indication, and if they're not, if they're using it properly for whatever non-FDA indications they have. So new drug being added to a formulary or being prescribed. Implementation of a guideline or protocol. Dr. Lee actually mentioned this. There were several different guidances and protocols that she's developing in her clinical practice. It's the same thing for the pharmacy in America. We have many different protocols that people have to follow. Are they being followed correctly? Are we using those medications per the protocol that was outlined? Then we also get into the phase of safety. So when processes don't work. This is when we bring a drug in and all of a sudden everyone decides to start using it. I have a couple of examples for that. So during the COVID pandemic, we really didn't have a lot of literature that got published. And if it was getting published, it was getting published rapidly. It was getting published with potentially some outcomes that weren't necessarily appropriate. However, once those publications happened, not all the time do providers read the fine notes. They may actually just read the abstract saying, hey, I think this works, we should try it. So in those instances, what do? Do we let them do it? We don't have any better literature. Okay, so at a certain point, there has to be a threshold in which individuals start making those decisions. But what does that mean at a hospital institution? Well, that's when we start to run into adverse effects. We start to run into safety parameter issues. And that's why it might actually trigger a medication use evaluation, because people start to increase their prescribing, but we don't even know if it's helping. However, we do have a system that anonymously can submit adverse drug events, and people are saying, hey, this happened to my patient after it was started by the doctor that came in before me. We should look into this. And so those are markers that we'll start to see where it kind of indicates, okay, we should look at the data as a larger subset, right? Maybe it wasn't just that one patient, maybe it's happening to multiple people. Poor clinical outcomes. So providers don't necessarily do their own research. They are prescribing, then they're going to the next patient prescribing, going to the next patient prescribing. They're very busy, and sometimes patients only get to be seen for 20 minutes, maybe 2-3 times a year by a specific provider. And they may not be able to measure how well those outcomes are coming in. So you want to see if there's starting to see some splatterings of other things happening. Our patients aren't doing well. As an example, for my hospital. So we actually got metrics back from an organization, so our governmental organization saying, hey, guess what? We're noticing that patients who have sepsis are not doing well at your hospital. So when we start to get some of those notes of feedback, that's when we start to investigate. It triggers a medication use evaluation, triggers some sort of process evaluation of, okay, how are we actually managing these patients? And then the last in terms of process failures or optimization needed is excessive drug waste or cost. This is very crucial for pharmacies in the inpatient world. When we bring in a medication, we have to figure out all the logistics. Does it need to be compounded? Do we store it in automated dispensing machines that are outside the pharmacy so that everyone has access to it? But all of a sudden, now we have to worry about expired drug. We have to worry about a provider saying, oh no, I don't need it anymore, but that was a $20,000 drug that we just compounded. So when we start having excessive waste or costs because of these medications coming in, it starts to spur a conversation of, okay, do we actually need to bring this in, or should we be using this a different way? The last thing is regulatory or hospital directives. So kind of similar to what we talked about with sepsis and our outcomes, there's many other reasons outside of the hospital that might actually spur a medication use evaluation. So there are several different drug programs that are instituted to help with offsetting drug costs for hospitals that acquire drug. So manufacturer makes a drug, the hospital says, hey, I want to start buying it. Well, they don't go directly to the manufacturer all the time. Most of the time we're going through third-party vendors. And the neat thing is we get incentives sometimes going to those third-party vendors, and we get cheaper discounts because we're starting to use it through those programs. The second one is a quality improvement measure, and I have an example that I'm going to talk about later. But similar to sepsis, there's many different measures that the government is looking at saying, hey, you know what? Hospitals, you guys are not managing these patients the right way. Here is a set of guidances from us. You better follow them or you're not going to get reimbursement. At the end of the day, though, everyone should, because they recognize that those are the best standards out. Okay. So we talked about what actually could cause a medication use evaluation to be triggered, but what do we do after that point? All right, let's dig in and start diving into the data. That's probably one of the worst things to do in these situations. And the reason for it is that there has to be a method to the madness. Otherwise, you'll be collecting data, you'll be collecting as many data points as you can on top of all the work that you're doing as a clinician. So you really need to think about, what am I actually trying to measure? What are the most important outcomes for my patients? And a lot of the time, it's not the same thing as those clinical drug trials that actually brought the drug to market, right? Okay, I know that this drug reduced blood pressure, but should I be using this drug or the other drug that reduces blood pressure in my hospital? What are the reasons why I would do one versus the other? And that's actually what a medication use evaluation is intended for, is to refine the practice within the institution. So the most important thing, and I'm going to talk about this in a couple slides, is really your objectives and wanting to refine that, because if you have more than one objective, that means you have more data points that you have to collect, which means that's more time of research spent outside of the practice that you've actually been trying to cultivate in your clinical work. So I usually recommend 1 to 2 objectives for any type of medication use evaluation that you're building. And that's to help refine just the main bullet points of what are we trying to measure in terms of efficacy, safety, or another type of improvement. The second thing is kind of figuring out what criteria you want to bring in. So this is thinking about what data needs to get pulled in order to measure the objective accurately. And so we'll talk about a couple of those topics in the next slide. The third thing is figuring out your baseline data. So most randomized control trials or most studies, you have all the data at your fingertips and you can probably access it fairly easily if you've got a data subset. However, in clinical practice, we don't always have that data readily available, and a large part of it is because of the HIPAA, so patient protective information. We can't easily start pulling from data from charts because we don't actually know all of our patients. And so you actually have to start thinking about what types of data am I going to need to get the bare minimum done, to measure the outcomes, to actually understand what patient population is being affected. So the more data points you have, the more intense the data collection, and it makes it really arduous for a clinician because you don't have the time. All right, and the last thing is if you have a lot of data points that you do need to collect, oftentimes you just need to refine your sample size. So similar to clinical trials, right? You think about, okay, what's the bare minimum number of patients I need to just get it through the data? So oftentimes when we do medication use evaluations, we think more about data ranges. And 1 year is a good staple. However, you may not necessarily need that if you have a large number of patients that are getting prescribed in a shorter period of time. So that makes a really big difference because all of a sudden if you get a report back for a year's worth of data and you've been prescribing the drug about 100 times a day, that's tens of thousands of patient lines that you're going to have to scatter and dig through. Okay. So how do we determine criteria? It usually is defined in 3 major buckets. You've got assessing for safety, and that's the most important thing about a medication use evaluation. The next thing you want to identify is what types of efficacy data points do you want to pull? Because most of the time you're not looking for what the drug trials proved. You're really looking at more refined data points of efficacy and how you would actually measure it in the hospital. Yeah, the blood pressure was reduced by a certain drug. I know that. But what we're really looking for is, okay, the blood pressure reduced by a certain drug, but did it get reduced in the right time, right? Was it quick enough? Did it get reduced for a longer period of time, right? Because now we're starting to come up with nuances between the drugs. Okay. Adherence rates, a lot of times people think about this in terms of patients. What is their adherence rate to medications? In hospitals, we think about adherence rates in terms of, are our prescribers prescribing and ordering the drug the exact same way, or are they ordering it differently? Are our pharmacists recommending the drug the exact same way? Are they recommending dosing the exact same way? And if not, is it to the protocol that we had designed out? And if it's not, is it safe? So that's the kind of overarching themes that we look at in medication use evaluations. All right, I know I've harped on this a lot, but the main reason for it is because your objectives are the biggest piece of a medication use evaluation success. If you don't measure the right thing, there's a good chance you're probably going to have to do another medication use evaluation again for the exact same drug that you tried to already measure. And at that point, we're wasting everybody's time, particularly yours. And the reason why I bring this up is students in pharmacy school in America are taught medication use evaluations. And so these principles are so important for them to learn as they're becoming clinicians, because they could start to do research, but then they would kind of be scrambling and circling the drain because all of a sudden, all the things that they started to collect in terms of data doesn't have any meaning in the grand scheme of how we're using it. Okay. So major different objectives that we're looking for to help refine what your data you're going to collect and what outcomes you're going to measure are really promoting optimal drug therapy, improving patient safety, standardizing and reducing unnecessary variation, optimizing drug therapy, assessing value of innovative practices, meet quality or regulatory standards, and minimizing costs. And so later on in this presentation, I've actually got several different examples of essentially principles I've used for medication use evaluations and miniature use evaluations of some of these objectives. Now, the big point to make is your objectives can change based on what you're actually trying to target. So are you trying to target that a therapy is working, so therapeutic outcomes, or are you trying to target that a process is working? So not necessarily whether the drug works, but that your providers or your pharmacists are doing the correct things with that drug. Okay. Overcoming other challenges. So we're all here to talk about our practices, but the other piece is the barriers in terms of doing research in the clinical setting. When you're practicing, your most important piece of your work is your patients. Day to day, making sure that each patient that you touch is getting better and not getting worse from the things you're doing. And so some of the challenges with MUE is the amount of time that it takes and the resources you have at your fingertips. Most people who are practicing and in clinical work, they actually don't have a lot of data that's coming back. And so you have to make requests to a different department, the IT department, saying, hey, I have a report I need to get. Luckily, the electronic medical record has become so much more refined. There's many different softwares in America, and the largest one is called Epic, and that has a lot of reporting capabilities where you can actually design your own report and pull information for patients. So it helps reduce the amount of extra work or other people having to get involved. But it doesn't pull all the data you need. Manual data collection process is pretty much the bare bones of a medication use evaluation clinical work. There's not a lot of automation that goes digging through electronic medical records, and so you really kind of have to recruit students, interns, other kind of learners to help you with the process. So the next part is the doing phase. If you start to recruit more than one learner or are involving more than one person, people could start collecting data differently. I know that sounds kind of strange, but when you think about it, going into a patient's chart, it's not going to look the same for everyone, and you're not going to pull the exact same data. And so what you oftentimes need to do is standardize it with questions. So they have a specific question that either is a yes or a no or categorical information, and that helps to really clean up the data going through it. And then the last thing is minimal data analysis tools. So you actually saw some beautiful charts from Dr. Lee. Not all the time is that software readily available for us to actually use. And so a medication use evaluation becomes a lot more gritty. You just have to get through basic statistics. You try to do a basic comparison of this versus that drug or this versus that practice and come up with some data that way. Okay, so the next most important steps happen to be in developing solutions and implementation phases. And this oftentimes gets missed or dropped after a medication use evaluation occurs. And the reason for it is because the MUE was exhausting. Oh my gosh, I just spent all this time collecting information and data and I've got results. Yes, I'm done. Well, no, we still have to figure out what's the best process and how to implement it. So best desired practice may not actually be the most feasible one. If you have solutions that require a human being to actually improve the process, that's more resources. We may not have that. And so you really want to leverage technology to make it the best you can. So our advanced EMRs in America really are leaned on when we come up with solutions. And I'll have some examples. Challenges in implementing recommendations or follow-up on solutions. So this is the part where I'm talking about this PDCA cycle, where people don't necessarily come back to the table saying, hey, we'd made a change. Did the change make things for the better? So that's also the piece where a lot of people forget. They forget to come back, and you have some of these committees that actually have to hold people accountable because they went back to do their regular work. They're done. They don't want to deal with anything else. You have to pull them back in, bring back those conversations, get the teams back to the table to talk about, okay, we made a change. Did the change work? Okay. So let's actually do an example of an MUE practice. And this is one of my most recent examples that brings in a couple of different concepts. So we have optimal use of IV calcium channel blockers in a hospital. My hospital approved a new IV calcium channel blocker, clofidipine. However, we decided to keep nicardipine on the formulary because there were some differences in pharmacokinetics. So we had a full year of usage, unrestricted, unmonitored. The providers used both medications, and they actually had the same ability to order those medications. There wasn't any restrictions. Then I had a clinical specialist. So my emergency medicine pharmacist, who is a clinical pharmacist on the floors, he rounds with the emergency medicine physicians every day, was like, hey, you know what? I just found a bunch of retrospective papers, and this might actually mean something. What he noticed was that clofidipine actually was creating rebound hypertension. So once you start the drug, it's a quick onset. However, it would actually not work as quickly after a certain amount of time. So it actually would rebound the patient's blood pressure and actually causing worse outcomes, especially for patients that actually needed a blood pressure reduction for a longer period of time because that blood pressure causes stroke. The other things that he noticed was maybe that the drug companies, the way that they studied it, the minutia in the way that they studied it actually doesn't make a difference in clinical practice. So here's an example. There have been drug studies that have compared drugs, so blood pressure reduction, and sometimes they'll say this was statistically significant because it led to an 8 millimeter mercury reduction. 8 millimeters of mercury. Well, someone's normal blood pressure is 120, and let's say their blood pressure is 140, which causes hypertension. 8 millimeters only gets you to 132, right? So that's actually not as much of a blood pressure reduction as we're hoping for, right? But it came to market because FDA said, this is effective, it can work. However, now it's up to the providers and physicians to decide, okay, should we be actually using it? Do we need to use it a specific way to actually get a better efficacy? Okay, so those are examples. And that's what we did, is we brought that medication in. So the trigger was we brought a new medication to formulary and physicians started using it. Okay, so here we go through the whole planning process of an MUE. You've got your objectives. So I chose one objective, compare the use of clofidipine versus nicardipine in the hospital. And then I chose the appropriate criteria. I didn't really care about blood pressure reduction. We knew both of those drugs reduce blood pressure. But my question was, in the literature, it says that we need to have rapid reduction of blood pressure and we need to have sustained blood pressure reduction for patients with stroke. I'm not as worried about some of these other patients where we can easily transition to an oral therapy. So I'm actually only going to focus on stroke in this MUE. And the baseline data, I don't have time. I have about 20 other pharmacists that are looking to improve a practice. I've got my manager saying that there's a regulatory body coming in. All right, let's just do the bare minimum. I'm going to look at where or who is actually prescribing this and what is the actual indication, because that's all I really care about. And the last thing is my sample size. So we had quite a bit of usage of clofidipine, and we got to at least see all the different orders. But now I'm going to refine my sample size of like who and what are being prescribed, because I have to go into every single chart to find those indications. Okay. So here are the results. Clofidipine versus nicardipine, and this is who was actually using it. So you can see that the emergency department is my lowest clientele in terms of using the new drug. However, the ICU in both nicardipine and clofidipine are using it. So that's telling me that we're probably needing to use this more in the ICU. Okay, that sounds appropriate. However, when you do a deeper dive, those indications are so important. Now you're looking at ICU for stroke versus ICU and unrelated stroke. I'm not so sure I care about clofidipine use in anything outside of stroke because those outcomes have different measures. So that's what we had decided, is that, okay, we're taking a look at clofidipine versus nicardipine. Most of it's being used for non-related stroke. So why does that matter? Well, the reason why is we're looking at a side-by-side 6 months of March to July when we only had nicardipine on formulary. We had about 400 vials that were used in the whole year, and that was our cost. Then, May to September, when we added clofidipine and providers started using it, we had about 400 vials used in that 6 months, but we doubled our cost in the use of IV calcium channel blockers, and that's huge for a hospital. So, what did we conclude? 64% of clofidipine usage was inappropriate. And so in medication use evaluations, we're identifying what is appropriate practice, what is not appropriate practice, and helping the providers say, oh, we agree, based on the literature, based on our usage, we need to do something about this. So I actually brought this to all my physicians at the Pharmacy and Therapeutics Committee saying, this is actually how we're using the drug. This is the literature that we found. There is a risk of rebound hypertension if we don't actually transition people correctly. there's a chance that we shouldn't even be using clofidipine at all because nicardipine works just as fast. Okay, so my providers came up with this recommendation with me. We should be enforcing criteria-based use for clofidipine. It's going to be used for stroke. It's going to be used for other niche indications that they had deemed appropriate, and the ICU intensivists are going to have to follow those criteria. Good, we're done, right? Those providers are good. They've now got their criteria. Not so much. You're going to need a PDSA cycle, right? So after I implement all that, I now have to figure out how am I going to enforce that with the physicians? Well, the best way to do it is to integrate it into their ordering system within the electronic medical record. And the second thing is the role of the clinical pharmacist. This is why we become so important in the United States, is because we become that individual that's knowledgeable about drug information, that the physicians come to saying, hey, I want to use this new drug. And the pharmacist can say, you know what, this is a great idea. No, it's not based on the literature that we have. However, the hospital can decide this as well because we've also looked at the literature from a pharmacist committee. And so that pharmacist now is educated and helps to provide that guidance to any provider that they see. So then, what do I have to do next? It's going to be the next cycle. I'm going to have to check whether we actually were ordering it appropriately again, and then implement a new process if we weren't. And so the whole cycle perpetuates itself. It's a lot of fun. Okay. So the last topic I'm going to go over is going to be many of the other principles of MUE that I've used within my practice. And so I'm going to get to show you a little bit more about what I've done as a clinical pharmacist and some of the outcomes that a pharmacist actually had a hand in changing the practice at a hospital. Okay. So how many of you guys are familiar with antimicrobial stewardship? Has anyone heard about antimicrobial resistance? Good. So I believe we just had a question earlier today. How are we combating antimicrobial resistance in India? Well, I can tell you in America that we actually have governmental enforcement of an antimicrobial stewardship in every hospital. And the reason for this is because we need to find the experts. We need to find who will actually be accountable in making sure that people are using antibiotics correctly. And so we have a whole pathway. The CDC's actually made recommendations to develop a program from start to finish. And many of these finish points actually have to do with medication use evaluations and the PDSA cycle. So what do I really do within an antimicrobial stewardship program? We talk about formulary restriction, developing guidances for providers, and then the most important piece is that prospective audit and feedback. And so what I did as an infectious diseases antimicrobial stewardship coordinator was be that helpful prospective audit and feedback system. And that's within a hospital. Not all hospitals will do the exact same thing that I did. And so because my service was novel, that made sure that I should probably be looking at it from a researcher's perspective. How do I actually prove that that service is helping our institution? Okay, so here's how the service worked. We have physicians in the hospital that are going to be prescribing antibiotics for their patients who have infections. Well, they may have some knowledge on antimicrobials, but they don't have all the knowledge. And so we actually put together a team of specialists, and that those team of specialists actually encompassed a pharmacist as that primary leader. And so the pharmacist was specialized in infectious diseases and knew about antimicrobial stewardship program and how to manage it. And so we bring together an ID physician and an ID pharmacist. I worked with the ID physician every day for a couple of hours, but they were only there for maybe 1-2 hours at best. And so it was up to the pharmacist to be actually reviewing charts, clinically assessing patients, and reviewing antimicrobial therapy and deciding whether it was appropriate or not. Then what we do is we give the provider a call, letting them know, hey, you know what, this antibiotic is a restricted antibiotic and you're not using it the right way. So I recommend that you change to either X, Y, and Z, or they don't actually need antibiotics at all. I think we're good to de-escalate. So what happened after that? Well, we did this for about 2 years or so that I was actually there. Well, 3.5, I should say. And this is what I decided to look at. I wanted to know, what was my service providing to the hospital? Were we actually providing any value to begin with? And so I recruited a couple of residents who were eager and gung-ho to actually figure out what we were doing from a stewardship service, and they came up with this. They had their criteria that they wanted to look at. So we've got inappropriate use and de-escalation, de-escalation being a large part of what we did for that first year of that antimicrobial stewardship service. Now you notice year by year that we actually have a major difference in what types of recommendations we were providing. And that had to do with the fact that I implemented a restricted formulary process much more stringently in that second year. And so you're seeing the trends of my service. But the second thing I wanted to prove was, does an antimicrobial stewardship specialist make a difference compared to all the other pharmacists who are practicing on the floors? And sure enough, when I looked at our acceptance rates of our teams, so providers who were accepting our recommendations from that stewardship service, you notice there was an 82% acceptance rate compared to all the other pharmacists that were making interventions saying, hey, are you sure you want this antibiotic on board? It was only a 71% acceptance rate. So what this did was essentially help with job security, but it proved that this service is really effective in helping to empower a pharmacy specialist team and really providing that resource for that hospital of they know who to go to if they have questions about antibiotics and they don't have time to talk to an ID consultant. Okay. So that was one of the very first projects that I did as a stewardship pharmacist. The second thing I did, and this was during the pandemic, was a new set of guidelines came out. So remember that trigger? New set of practices came out. Vancomycin historically was used, and the way that we would measure vancomycin levels is just by troughs. And so a lot of guidances came out saying, you know what, you're just going to measure a trough. This is the gold trough. However, in pharmacy school, when we learn about things, troughs aren't meant to measure efficacy. However, that's exactly how we were doing it in America. They were measuring it for safety and efficacy. Now, as a resident, I said that, I was like, I don't understand why this is possible. However, when the guidelines came out, I was like, that makes more sense as a pharmacotherapy expert and learning about the pharmacokinetics of drugs where a peak is more effective in measuring efficacy. These guidelines are starting to make more sense. So I immediately wanted to implement a change, and I developed a set of protocols that all the pharmacists had to follow because we'd never dosed vancomycin this way before. In addition to that, it was much more of an intensive process, so I had to train everybody to actually learn how to dose it properly to get the right levels to prove that we were getting efficacious and safe levels. Okay, so that's what I did. I implemented a training and competency. We went live with the protocol. We did some data analysis to see how we did, and these are our results. So as I did the data analysis, I knew what I needed to measure. We had everything in the chart, which was helpful. But we wanted to look at how well was my pharmacist actually following protocol. So my goal is greater than 90%. Initial target goal attainment, I wanted it to be greater than 70%. And then acute kidney injury. So most literature out there I showed vancomycin itself has an acute kidney injury incidence of 15%, which is pretty terrible if you think about it. That's a lot of patients that get hurt from vancomycin. But I at least had some standard to go by where I was like, okay, let's at least try to meet the bare minimum of what the expectation is across the literature. So most of the time, you really want to create regular reporting when we're looking at safety measures like this for a medication use evaluation. But this was the initial rollout. So I looked at May and July as two different bullet points of the data. Vancomycin's used a lot. So I had to pare down my data and the places that I was going to choose to audit. So I took a look at the data, and our protocol adherence, we had about 56% adherence in May, which kind of makes sense, right? I just rolled out a new protocol. If my new staff coming in don't know how to do it, they're still kind of figuring things out in terms of documentation. Then I took a look at efficacy. So the neat thing about this is we know that an AUC to MIC of greater than 400 equals best outcomes. We've seen that in the literature, right? I already have literature to prove it. Now I have to prove, am I meeting that in the hospital? And this is where your research meets your practice. And this is so crucial when you already know those goals. And unfortunately, this is where we were really running shy. My goal of greater than 70% of hitting an AUC to MIC of 400 after the first level that were drawn was super low, even on both times. Luckily, it went up from May to July, but it sounds like my pharmacist still needs some help knowing how to optimize the dosing of vancomycin. And then the last thing that I loved, and this is exactly why I did AUC to MIC implementation compared to trough-based monitoring, was the acute kidney injury. Notice it went from 12% to 8%. This is the biggest piece of healthcare practice, right? We want to reduce injury and, quite frankly, any adverse events that we're causing patients in the hospital. So now, seeing that it reduced acute kidney injury, definitely the better way to dose vancomycin. So there is obviously room to grow, and that's what you see in medication use evaluations, right? My recommendation at this point is I'm going to need to figure out how do I get a better target attainment sooner on a patient's course rather than later, right? Because we know that we need vancomycin for MRSA coverage of an infection. Okay. So the next study that we took a look at had to do with regulatory measures. Staph aureus bacteremia is one of the highest mortality rates for any patient that comes into the hospital. And the thing that we knew is that we needed to use certain medications that had the best efficacy, and this has to do with the literature out there. ID consultants, the minute they see a Staph aureus bacteremia or Staphylococcus aureus bacteremia, they're going to be changing the patient over to a specific antibiotic. Now, the interesting thing, and the reason why this is a quality improvement reporting, is because the CMS or the government got involved, and they said, across the United States, we're seeing poor outcomes when patients get Staphylococcus aureus bacteremia. Hospitals, you guys are required, and I need you all to figure out how to get these patients on the right therapy at the soonest time possible. And so that measure went out, and our hospital was tasked in making sure that we were starting patients on the right antibiotics sooner to help prevent mortality. Okay, so the appropriate antibiotics that we were looking at was nafcillin or cefazolin. And we were basically using a gold standard measure of how to manage these patients on bacteremia. So those are the things we looked at. So all of MUEs, as you notice, are retrospective. It's looking through the chart, looking at did we actually do the right thing. So it's not necessarily a proactive type of study, but that's how we actually start with baseline data. And so our baseline audit saw between the 3 different hospitals, this hospital right here did the best, right? We were closest to the goal of greater than 90% of patients changing over to nafcillin or cefazolin earlier on in their course, which means we probably had the best outcomes in terms of whether patients were dying from Staphylococcus aureus bacteremia. So this is our quality improvement department. They gave these measures to the leadership, and leadership was like, okay, this is a metric we need to actually start to look into. And so with leadership, they create tasks, they help to delineate resources, task force. That's oftentimes how specialists get involved in, increasing the accountability of some of these outcomes that are happening in the hospital. Okay. I was unfortunately part of that task force, unfortunately or fortunately, but that's how I got this data. All right. So what happened next after that baseline audit? Now we have to think about that process we talked about, right? So the recommendations, we have to have an outcome that's going to improve. So how do we improve that outcome in the hospital? It's the real world, just like Dr. Lee is saying. It's not pretty. We got to figure out how to actually make providers do the right thing. So you start to think about what is needed to actually make providers do the right thing. An automated ID consultation service, our ASP Watch service, we already shown that that stewardship program was super effective. Let's put them to task. This is a new thing that they're going to have to look at. Any Staphylococcus aureus bacteremia, they're going to be reviewing in the charts, and they're going to be reaching out to those teams proactively saying, hey, guess what? You should be switching them over to a different antibiotic. And then the last thing that usually happens is development of guidelines, right? We start to educate providers in a more kind of hands-off way, right? Because they're all looking for resources, but they don't want to read 50 pages of a national guideline. They're just going to want 1 or 2 pages of, this is how I should treat this patient, this is the hospital stance, and so those guidelines get created. Okay? So, in summary, medication use evaluations play a crucial role in clinical practice. It enhances patient safety through systematic medication assessment, promotes optimal medication management and adherence, facilitates the identification of safety and efficacy issues all the time, supports adherence to clinical guidelines and standards, and drives continuous improvement in the healthcare system. Ultimately, I've been doing MUEs in one fashion or another for a very long time. The biggest things that I have learned through these is that you always have to start with the end in mind. What are you trying to measure? You don't want to waste time on data that's not going to give you any results, but it makes you feel better, but no results, right? So those objectives are key. Then the next thing you want to do is detail out your data collection process. You want it to be as consistent as possible. For retrospective studies, oftentimes the data coming in is not going to be clean, right? Because you don't have someone that's actually measuring it on a study proactively. You're collecting it from the chart. Everyone measures and everyone takes notes differently, and so you have to have a clean data collection process to streamline it. So, as I talked about in my title, it's not pretty. You just have to think practically. Use that left side of your brain and think about what are all the different objectives, how are you going to measure it, what are the logistics to it, and at the end, maybe you can make it pretty with some slides. All right, so the last thing I have is just future directions. I'll probably be doing the same things that I'm doing. My favorite thing to do in a medication use evaluation, though, that I found is really kind of looking at a service and looking at how my pharmacists are practicing in the hospital and deciding how can I make their lives better. And so when you think about a medication use evaluation, a lot of times people think about it after something has occurred, right? Whatever that trigger point is. But in your career, to do research, you want to be proactive. So the things that you're going to think about is when you implement a flow or clinical practice, what are things you actually want to document? What are things that you're going to start to kind of create notes for yourself? Because when you start to do that, you actually create your own data collection process proactively. And then afterwards, you get to just crunch the numbers at the end. And so that's actually how I was able to do quite a few of those MUEs throughout my practice. All right, thank you.
Thank you, ma'am. We would like to express our sincere gratitude to Dr. Bethany Carpenter, ma'am, for sharing her valuable insights with us.
Now, we will open the floor for questioning. If you have any question or query, please raise your hands. Mic pass.
Good afternoon, ma'am. Ma'am, I have two questions. What are the risks and at the same time, what are the benefits of being in this type of study?
Yeah, so the risks are really in the retrospective process, right? When you have to commit yourself to a study that was done just by collecting data in the chart and things have already occurred, you're not going to get clean data. You're not going to get consistent measures. And that happens with pretty much any retrospective study. When you do a cohort or a controlled, class-controlled study, case-controlled study, you're going to get data that's all over the place because it was whatever the physician decided to write that day, or it was whatever the prescriber decided to do with that medication. And so when you have unclean data, you can't get consistent results out. And so that's kind of why you have to be very methodical in your objectives and know exactly what you want to measure, because oftentimes you're going to have missing data. So that's the risk, right? And the more data you have to collect to actually come up with the results, that makes it arduous. The benefits, and that is actually exactly why we do medication use evaluations. So most of the time when we're doing a medication use evaluation, we want to know whether a practice is safe. And a lot of times when you're looking at clinical trials, when you're looking at safety parameters, we don't notice a lot of that originally in randomized controlled trials, right? I think we talked about thalidomide earlier today, right? We didn't notice thalidomide was an issue until it came out on the market and we started using it. So the neat thing about retrospective studies is that's actually how we find a lot of our safety data. And it happens because we look at correlative measures and then we do deeper dives of what might be happening. So that's the benefit, is a medication use evaluation does exactly that.
As a student, can we join this type of research programs in hospitals?
Yes. It's actually the easiest thing to get involved in as a student and as a pharmacy resident. So when we talked about residency programs in Taiwan and residency programs in America, a lot of times the poster presentations that they're presenting, like all of your guys' posters, it's mostly medication use evaluations, right? Hospitals want to know what other hospitals are doing. And a lot of times those MUEs are published. And that's actually where I actually got some of the standardized data. So the slide I talked about with antimicrobial stewardship and that service and my acceptance rates of a pharmacist versus a antimicrobial stewardship program specialist, that data tracked similarly to other published data in another hospital. So they did their own MUE of their stewardship service versus their pharmacist, and they found that exactly the same. 70% acceptance rate by a pharmacist when they made the recommendation to a physician, but then when you did a stewardship service, a specialized service, you had about 84, 85% acceptance rates. So the neat thing about it is you can publish as a student, and that's where you can get started. So outside of starting at meta-analyses and systematic reviews, medication use evaluations, if you're practicing in the hospital, that's the best way to get started with research.
Thank you so much.
Thank you, ma'am. Ladies and gentlemen, we are now poised to embark on a discussion that promises to be both insightful. Yes.
Yes, okay. So how do I validate the data? So remember when I said it was practical and not pretty? Validation of data has to come with what the person decides. So most of the time, in terms of validating data and whether it's true or not, we're going to be using other literature. So we base it off of what other people have published, and if we found the same outcome and we found that it correlates to randomized controlled trials and some of the information they had there, that validates our data. Now let's say we're measuring something completely novel. The only way to validate the data is to make sure that your data points and the protocol you have designed for medication use evaluation helps you pull the exact information from chart to chart. And so that's really the best way to validate it. Until another study comes out or another study or another hospital says, hey, we did the same thing and found those results, that's unfortunately the downside. Is there any analytical data that or protocol that you use to validate it? Is that the question? Depending on how developed your MUE is, and if you are in an academic institution, some software can help to validate it. Is that me? But oftentimes, there's really not a ton of software that can be used.
Hello. Okay. Thank you for a nice presentation, ma'am. I have some doubts and some query about the medication use evaluation process. The first one is that, is there any specific number of data entry for a particular drug is required? It means like clinical trial, the government prescribed the number of patients or the number of respondents in any study. It means for this kind of a study, 1,000 patient data is required. In that case, is there any specific number of volunteers or patient data is required? Okay. Second thing, suppose if you conducted a study medication use evaluation for a particular drug in your clinical research center, and one other institute also doing the same thing, how many percentage chances the data may be vary in comparison to study conducted by two different institutions? Yeah. And third one, suppose data is analyzed in collaboration with drug interaction study for a specific patient. So in that case, the number of volunteers and the interaction with different type of drug, it's very difficult to assess a specific drug medication use evaluation process, because multiple times it happened 2 to 3, 4, 5 medications will be prescribed by the doctor. So it's very complicated in that case. So how we can optimize this parameters?
Yeah, that's a good question. So the first question you asked had to do with how do you determine the number of patients you enroll in a medication use evaluation? So the easiest answer to that is you just pick a date range and you figure out how many patients actually were impacted in whatever data you want. Most of the time, that's usually how medication use evaluations occur. So I actually was part of 2 medication use evaluations this past year. One was the clofidipine you guys saw. It was about 220 medication vials, or 220 patients that you would see in that 6-month range that we took a look at. And that was the data subset that I decided to choose. That was more than enough for me to come up with conclusions. There was another medication use evaluation, though, where I was looking at a drug that wasn't used very often. I think it had maybe 10 patients at most that year that I looked at, but it was enough to come to conclusion. So the short answer is there's no real number. However, we do have concepts that we can use from clinical trial, right? So the concept of power is one that you could use. If you really wanted to advance your medication use evaluation studies, you could actually use the concept and calculate power. Now, that actually has happened in previous studies that I've had colleagues work on. And the way that you would do that, though, has to do with past literature, and that's how power is calculated. You have a couple of different studies that show either it had a statistical significance or not, and you use that as a part of your calculation of like, okay, I need at least these number of patients to help me identify if this medication made a difference or not. So that's one way to do it. The second question you asked was about yes. Okay, so how do you make a recommendation when you have another institution with a different patient population? And that's a really, really good question, and this has to do with collaboration. So a lot of times medication use evaluations will occur amongst different institutions because they have different patient populations. And so you can discuss your results with other institutions. That's exactly what poster presentations do. But then that's where your drug information knowledge and your clinical awareness of how to break down that study and find its weaknesses is so important, right? You start to look at what were the differences in our patient population that may not make that paper that they're talking about or their study applicable to ours, which also prompts the reason why you might need to do a medication use evaluation in your own hospital, is you have a different set of patients. Just like Dr. Lee mentioned about her dosing of Alteplase, where the standard dosing for most places, including the United States, was a certain type of dose, 0.9 milligrams per kilogram. But she noticed in her patient population, which is primarily Asian, they don't need that dosing, right? So then now you're coming up with the differences in patient populations. And then the third question you asked. Oh, yes. Okay. So what do you do when there are multiple confounders in order to identify the results of the study being valid? When you're designing a medication use evaluation, that's actually a part of the planning process. So, for example, my vancomycin use evaluation, I knew that acute kidney injury can happen from multiple different things, not just vancomycin. Aminoglycosides, contrast media, the patient could just have a hypotension where they would normally get acute kidney injury for a long sustained period of time where they don't have a high enough blood pressure to give blood flow to the kidneys. So when you're doing a medication use evaluation, you're identifying all the different things that could possibly impact your results, especially if your objectives are clear. Yeah.
Thank you, ma'am. Ladies and gentlemen, we are now poised to embark on a discussion that promises to be both insightful and impactful. Before we delve into the heart of the matter, it is essential to understand the framework and objective of this session.
May we have the privilege of inviting our session chair, Dr. Nilesh Malviya sir, to share his thoughts about the session.
Hello. I'm extremely thankful to Ms. Bethany Carpenter for her everlasting enthusiasm during the technical session. It was wonderful hearing you throughout the session. Madam, with theoretical as well as practical recognized evidences, highlighted the impact of medication use evaluation. She also gave various examples, clinical practices, insights related to medical use evaluation of few drugs. Thank you for sharing your amazing experience. Madam covered all the aspects of medical use evaluation, including how to focus on MUs, various objectives, research aspects, various challenges in designing the medical use evaluation of any drug, criteria for evaluating the medical use evaluation data, what are the various guidelines affected the medical use evaluation processes, and how to practicize with the clinical aspects of any drug with the concept of medical use evaluation, what is the PDCA process for the evaluation process, the ASPH guideline and other guidelines also. So now as the chairman of this session, it's my honor to propose closing remark for today's second technical session of this international conference. It was an honor more than pride to be present for this incredible technical session. Our experienced speaker, resource person have given informative insights which are valuable for one and all, especially for our student that other than B pharmacy and M pharmacy, what kind of career objectives and opportunities are available in the clinical practices. This type of study definitely give a direction to plan your future study, future project, research work, and also career also. It goes without saying that organizing team have wonderful work on this today's international conference topic, have done wonderful work and wonderful job. Thanks to all for organizing such a wonderful event and invited such a experienced speaker who gave some good insight about the recent topic, recent practices and recent clinical studies and what exactly they are doing in their country. So it's a very inspirational for all of us. Thank you. Thank you once again. Thank you, ma'am. Thank you. And she deserves a big round of applause. Thank you very much.
Thank you so much, sir, for your valuable words on this session. Your words has added great understanding. We truly appreciate your time and expertise.
We are now going to take a moment to reflect on a significant memento that holds a deep meaning. This object serves as a beautiful reminder. Now we would like to present memento to our esteemed session chair.
And for that, I request Mr. Rampal Mandlovi, sir, to present a memento to Dr. Nilesh Malviya, sir.
Thank you, sir. We would now like to acknowledge the valuable contribution of our keynote speaker. Please join us as we request Dr. Nilesh Malviya, sir, to present an appreciation certificate to Dr. Bethany Carpenter, ma'am.
Please joining us in thunderous appreciation. As we move forward with the program, we would kindly request our esteemed speaker and session chair to occupy their seats of the dais.
As we come towards the end of our scientific session, we will take a short break of 10 minutes and will join back for the valedictory section.
Thank you.
Everyone, please be seated on your respective places.
So after valedictory function, we will have a 10 minutes break. We will continue with the valedictory function. It is just 15 minutes program. I know after lunch.
Good. As we approach this significant hour of valedictory session, it is our profound honor to acknowledge and welcome the expert panel of judges who have played an instrumental role in evaluating the scholarly contributions presented during this esteemed conference. With an absolute honor, I would like to welcome our all judges over dais and will request Dr. Prabhat Das sir to escort them. Please ma'am, please sir. Please everyone, I would like to request Dr. Nilesh Mandle sir to come over dais and present a floral welcome to our judge, Dr. Sapna Malviya ma'am. Sir, please. Welcome, sir. Please give a huge round of applause. I kindly request you, sir, to welcome Dr. Nitin Deshmukh, sir, with a bouquet. Please, everyone, gather up with applause. Again, I would request you, sir, to present floral welcome to Dr. Ankit Sharma, sir. Please, everyone. Now, in my words, I would like to shortly brief about today. Today, we all are clustered here from across the globe to witness and be a part of second GRYPICON. Initially, we inaugurated our conference with auspicious lamp lighting ceremony and then followed up with a ritual of certificate signing by our Honorable Chairman Sir, keynote speaker and chief guest. During the entire day, we have witnessed groundbreaking discussions, insightful deliberation, and also innovative perspectives from our speaker and session chairpersons. It has truly been an inspiring experience to witness how they created flow chain and aura of knowledge within this hall. The main motto of this conference was to bolster the advancement and global innovation in clinical trials. And to fulfill it, we had two in-depth speaker sessions by our paramount speaker, Ms. Alice ma'am and Dr. Bethany Carpenter ma'am. And they were accompanied by our wonderful session chairperson, Dr. Nilesh Malviya sir and Dr. Atul Eshir Khedkar sir. And between this session, we also had our meal. And now we are continuing our program's last part, valedictory session. Today, we all are very fortunate to have such bright mind as our judge of poster presentation, where the judge of offline poster presentation are Dr. Sapna Malviya ma'am, Dr. Nitin Deshmukh sir, and Dr. Ankit Sharma sir. And the judges who are presented on web with us, they are Dr. Rakesh Punasya sir and Dr. Shantila Singune sir. They both aren't present here. Dr. Sapna Malviya ma'am. Professor Dr. Sapna Malviya is a renowned academician and expert in the field of pharmaceutical sciences, currently serving as the head of institute at Modern Institute of Pharmaceutical Sciences, Indore. Her contribution to education and research are highly regarded, and she has achieved numerous accolades, including the Best Teacher of Pharmacognosy Award, Distinguished Professor Award, and also been honored with Academic Brilliance Award. It's a great achievement. Then we have Dr. Nitin Deshmukh sir. Sir currently serves as principal of Mangaldeep Institute of Pharmacy in Aurangabad. He completed his PhD from DAVV Indore in 2024. Dr. Deshmukh has authored 5 books, 3 patents, and 20 publications of national and international repute. He also attended 20 national and international conferences throughout his career. Then we have Dr. Ankit Sharma sir. Sir is currently established as Professor Sri Sahaj Institute of Pharmacy in Khargone. Completed his doctorate from Sunrise University in Pharmaceutical Sciences, Alwar. Sir is well recognized for his contribution in field of pharmacy and pharmaceutics through research and development. Then for online poster presentations, we have Dr. Rakesh Punasya sir. He holds the position of principal at Yogeshwar College of Pharmacy in Badwani. Completed his doctoral studies in Pacific University in Udaipur in 2015. Sir has published 16 research articles in national and international journals and has attended nearly 14 conferences and FDPs, including 9 presentations at national and international venues. Dr. Shantila Singune sir, currently he serves as head of pharmacology department at Institute of Pharmaceutical Sciences, Sage University, Indore. Sir has achieved his doctorate from Bhopal Nobel University, Udaipur, and he published 35 papers in which 10 are international and 25 are national reputes. He also authored 5 books in several books and received 2 patents. Thank you all the judges for glorifying event. Sir, Prabhat Das sir is here. Sorry sir. Now the moment we've all been waiting for, the time to reveal the result of poster presentation. Each of these posters represent hours of hard work, deep research, and creative thinking. So let's encourage our presentation who participated with a huge round of applause. Please, everyone. So, please, everyone, behave. So, to announce top rankers of poster presentation, I would like to invite Dr. Prabhat Das, sir. Sir, please.
Good afternoon, everyone. It's my pleasure to announce the winners of our online and offline participants. We had some truly outstanding presentations by the authors of all over the India, and it was a very really a tough decision for us to take any winners, but our judges and our scientific team did a tremendous job to sort out the winners. So the time has come to felicitate these winners. So in online category, The winner of the third position is tied between two participants, that is Dr. Kusagra Dubey, Smriti College of Pharmaceutical Education, Indore, and Miss Japman Kaur, Manipal College of Pharmaceutical Sciences, Manipal. Next winner of our second position is Mr. Aniket A. Timle, Institute of Chemical Technology, Mumbai. Now finally, the winner of first position is Dr. D. Sridhar, Manipal College of Pharmaceutical Sciences, Manipal. We have a consolation prizes also for Mr. Prashant B. Gaurav, RK University, Rajkot, Gujarat. So these are our online category winners. And in offline category, I want to acknowledge our sponsor for X-Farm prize for the best poster presentation from Bureau of Health and Education Status Upliftment. Winner of the third prize with a prize of amount 1,000 goes to Miss Nidhi Namdev from GRY Institute of Pharmacy. Please, Ankit sir, please felicitate. So next, winner of the second prize with a prize amount of 1,500 goes to Miss Rajni Shah, Oriental University, Indore. Nitin sir, please felicitate Rajni madam. Thank you very much, Rajni madam. Finally, winner of the first position with a prize amount of 2,500 goes to Mr. Jeevandeep Misra, that is Indore Institute of Pharmacy. For that, I request Sapna madam to That's not all. We have consolation prizes also. The consolation prizes of amount 500 goes to Miss Pooja Punasia from GRY Institute of Pharmacy. Sir, Ankit sir, please felicitate. So we have another consolation prize of amount 500 goes to Miss Pooja Kumari from Sage University, Indore. Please, Nitin sir, please felicitate. Thank you, Pooja madam. We appreciate everyone who took time to prepare and present in international conference, and thank you for audience for your patience and appreciation towards our winners. That's all from my side. Thank you very much.
Thank you, sir. As a token of appreciation and gratitude, we would like to represent Memento as our effusive effort toward judges who graciously lent us their time, expertise, and invaluable insight to examine and judge presented poster in conference. I would now like to request Ms. Sonam Kukloria ma'am to present Memento to Dr. Sapna Malya ma'am. Please everyone, gather up with a huge round of applause. I would request to ma'am to present Memento to Dr. Nitin Deshmukh sir. I would like to request ma'am to please present Memento to Dr. Nitin Deshmukh sir. I now request you ma'am to please ma'am present Memento to Dr. Ankit Sharma sir. Thank you, ma'am. I would now request all dignitaries present over dais to have seats off the dais. Please, judges. As we are near to the conclusion of today's enlightening conference, it is time to reflect on the journey we were embarked upon together, one filled with benevolent actions concomitant to spread knowledge. And following it to share their insight and experience of conference with us, I would like to invite Miss Alice, a prominent speaker of this conference, over dais. Please everyone gather up with a huge round of applause to welcome Miss Alice.
Hello, everyone. You can hear me clearly. So, good afternoon. That's after a long day of a very busy conference. I'm sure you've all learned a lot from the audience, from the speakers, from Dr. Carpenters and our distinguished guests, and Dr. Suji as well. So some of my personal thoughts throughout the day is, first, I feel so honored to be invited here all the way from Taiwan. So I think it is just like a journey. I really appreciate that Dr. Farrow came to the first international conference 3 years ago, and then me and Dr. Carpenter got a chance to be invited by Dr. Suji for that. So it is just so amazing experience for me. While preparing the trip to here, I kept wondering what is the content I can deliver, I can be sharing, what are the information you may be interested in. And here I learned a lot, not just from Dr. Carpenter's slides. I'm a big fan of antibiotic structure, so I was just keep noting while she's delivering the talk. But I also learned a lot from you, the students, the faculties, and the managers of us institutes as well. You all put a lot enthusiasm in pursuing your, whether it is the educations or careers or in terms of to getting a better yourself. So for us, it's a really, really short journey, short trip to visiting here in India. We only stay here for a couple of 4 or 5 days. But in terms of life, is also a journey to pursue, just like our career path. So I encourage all of you to keep pursuing, to keep developing. Do not limit yourself about where I should go or what I should be doing. So as some information for one of our audience had asked me earlier before, that I actually before I came to hospital, become a full-time pharmacist there, I actually worked as a research assistant in college. And before that, I went for the 4-year B-Pharm program. And then after the 4 years of training, I thought I still like something of more research-related experience. So I entered a master program for another 2 years. So after that, I got a chance to explore more national projects with our Taiwan's FDA requirements. So then I started working in a hospital. So I didn't expect that I will be showing up here, like doing presentation with you, with all its year-long experiencing. So it might happen to you as well, and you're all very potentials in doing that. So yeah, thank you. At the end of the day, I'm very appreciated.
Thank you, ma'am, to share such a beautiful depiction of this conference. As we have now arrived to the final moment of this remarkable conference, it is time to express our heartfelt gratitude to all those who made this event a grand success. So, to extend our sincere appreciation to everyone who contributed to this conference, I now invite Dr. Nikhilesh Birla sir over the dais to address vote of thanks to all of us. Sir, please.
Good evening all. How is the Josh? Okay. I, Dr. Nikhilesh Birla, feel honored and privileged to get the opportunity to propose a vote of thanks on the behalf of GRY Institute of Pharmacy, Borawa, on this special occasion. I am very much thankful to Dr. Bethany Carpenter and Miss Alice, invited guest of honor, Dr. Indrajit Singhvi sir, today's chief guest, Dr. Neeraj Upmanyu sir, invited guest for session chair, Dr. Nilesh Malviya sir, Dr. Atul sir, invited guests or invited judges, Dr. Sapna Malviya ma'am, Dr. Ankit Sharma sir, Dr. Nitin Deshmukh sir. GRY will always remain grateful to you for your support and guidance to shape this conference, and we thank you to all for being with us today. I would like to also thanks to all the delegates who made this event gracious with their presence. I, on the behalf of organizing committee Also thank to our respected chairman, sir, Sri Arun Yadav, sir, for his valuable support and guidance and blessings. Without his support, this event, we will not able to organize. My special thank to Sri Sanjit Yadav, sir, Senior Director, JNCT Borama, who made us or who helped us a lot to approve necessary administration approval to organize this event. My special thanks to all the sponsors and sponsors agencies, MPCST, BRNS, CSIR. My sincere thanks to all the GRY staff, teaching and non-teaching staff, and very well motivated student volunteers. So thank you to all for being with us today, and thank you to all to making this event successful. Thank you. Goodbye.
Thank you so much, sir. Now for refreshments, we are adjourning it for a short span of time. Use it well to network and connection with your co-attendees and get recharged for next session. And please don't be late, because after this valedictory function, our culture program is scheduled in a row. Please everyone, thank you. You may now proceed.